session will provide practical insight that we can apply to our daily day-to-day basis. Without further ado, let us begin. So, it is my pleasure to introduce to you our first speaker, none other than Dr. Nurul Liana Roslan, a consultant nephrologist from Hospital Kuala Lumpur. Dr. Nurul has extensive expertise in acute kidney injury and critical care nephrology with fellowship training in the UK. She is actively involved in clinical research, education, and National Kidney Health Initiative. Today, she will be speaking on perioperative renal protection, a topic that highlights how multidisciplinary collaboration can help us prevent perioperative kidney injury and improve patient outcome. Please join me in giving a warm welcome to Dr. Nurul Liana Roslan. Today, she will be speaking on perioperative renal protection, a topic that highlights how multidisciplinary collaboration can help
for the
us
kind
prevent
introduction.
perioperative
Morning,
kidney injury and improve
Thank
patient
you
outcome.
for the organizing
Please
committee
join
for
me
inviting me
in
to
giving a
speak
warm
today.
welcome to Dr. Nurul Liana
Quite a good
Roslan.
crowd
Today,
on a
she
Sunday
will be
morning. Well
speaking
done to
on
all.
perioperative
So
renal
I will begin
protection, a topic that highlights how multidisciplinary collaboration
on
can help
for the
us
kind
prevent
introduction.
perioperative
Morning,
kidney injury and improve
thank
patient
you
outcome.
for the organizing
Please
committee
join
for
me
disclosure.
in
They will
giving a
also
warm
give
welcome
me
to Dr. Nurul
everything.
Liana
Quite a good crowd
Roslan.
on a
She
Sunday
will be
morning. Well
speaking
done to
on
all. Let's start with
perioperative
so I
renal
will begin
protection, a topic that
so
highlights
post-operative
how
AKI,
multidisciplinary
the
collaboration
definition of
can
renal
help us
as renal
prevent
definition.
perioperative
Morning,
kidney
so
injury
you will
and
have
improve
AKI
patient
stage
outcome.
1 when your creatinine increase.
Please join me
disclosure.
in giving a warm welcome
Or
to Dr. Nurul Liana
quite a good crowd
Roslan.
on a
She
Sunday
will be
morning. Well
speaking
done
on
to all. Let's start with
perioperative
so I will
renal
begin
protection, a topic that highlights
post-operative
how
AKI
multidisciplinary
and definition
collaboration
of
can
AKI
help us
when you
prevent perioperative
morning. So
kidney injury and
I'm
improve
not
patient
sure if you are aware that new terminology.
Please join me in giving a warm welcome to Dr. Nurul
quite a good crowd on a Sunday morning. Well done to all. Let's start with so I will begin and so post-operative AKI and definition of AKI when you morning. So and I'm not sure if you are aware that new terminology.
Please join me in
giving
giving a warm
or
welcome to Dr. Nurul Liana
on Sunday morning. Well done to all. Let's start with so I will begin and so post-operative AKI and definition of AKI when I morning. And studies have shown that when AKI is defined by a KDIGO criteria of increase in creatinine, the incidence is about 8%. But when the studies included urine output as part of the definition for AKI post-surgery, it can rise up to 60% of incidence of AKI actually. Yeah. And as I've mentioned, because creatinine may lag, small rise may reflect substantial GFR loss, and in cases where patients fluid overloaded, fluid can mask AKI because you can get a diluted creatinine, so you may miss the patient had AKI. So don't forget, urine output is important. So and there is no single incidence that leads to post-operative AKI. These are all causes that can lead to AKI post-operatively. It started before the surgery and also type of surgery, and it can carry up to post-operative ICU. So the incidence varies according to the phenotype of the surgery, but mainly it has higher risk in surgery that involve the heart and also the vascular vessels, and also abdominal surgery. And because risk changes across the surgical course, kidney protection must begin even before the surgery, perioperatively. And post-operative AKI is common, but risk is highly procedure dependent. So this is the organizing framework for this talk. So I'll be organizing it from pre-operatively, intraoperatively, and also post-operatively. So these are the things that we basically have to look for to prevent AKI to happen perioperatively. So before discussing individual interventions, it helps us to understand why perioperative AKI is actually multifactorial, and protective measure must be taken in all these three phases to prevent patient to have post-operative AKI. So these are the pathophysiology in detail of what was the phenotypes that was mentioned before. So, so the main point here is that perioperative AKI rarely has one cause. So it can happen before, in the surgery itself, and post-operatively. So and baseline susceptibility means hemodynamic disturbances, inflammation, nephrotoxic exposure, and obviously the surgical stress during the surgery. So all these mechanisms actually induce acute tubular injury, and incomplete recovery can later progress patient from AKI, AKD to CKD. Yeah. So there's a lot of areas where AKI can happen. And that's why we have to look into all the specific detail. And truthfully, I think we all know there are no specific wonder drug to protect the kidney perioperatively, because KDIGO has recommended it must be targeted in a bundle. You know, so there must be a checklist of bundle that all these things must be taken care of to prevent AKI. So the first step, so the KDIGO AKI 2026 will come out soon. They have come out with a draft in April, but now reviewing comments. So hopefully by December, it will be finalized. So I will be presenting some of the KDIGO draft recommendations, but bear in mind that the recommendation may slightly change after they produce a finalized version in probably December this year. Okay, but mainly across 5 large RCT, if we follow this bundle, all this bundle includes hemodynamic, nephrotoxins, stewardship, appropriate glucose control perioperatively, checking medication, contrast associated measures, and also creatinine and urea output monitoring. If you take care of all this bundle, it actually has been proven to reduce risk of stage 2 and stage 3 AKI. So we will begin with pre-operative protection. So basically, this is what we do when we see a patient when you all see patient pre-operatively, when we be referred as physician to see a patient from our surgical colleague. So first thing we have to do is, of course, we have to recognize who are at risk. You know, and the risk is an interacting domains. It comes from all these aspects. Basically, it includes patient factor, procedure factor, and exposure the patient is having at that moment. So when we look at the patient, we have to check whether the patient creatinine is actually a CKD, or the patient is having ongoing AKI before the surgery, because patient who's having ongoing AKI that needs to go to surgery, the risk is probably higher than the patient who is having a stable CKD. And albuminuria is often neglected, but albuminuria is actually a marker of oxidative stress, kidney progression, and AKI progression. Age, frailty, diabetes, heart failure, liver disease are all compounding comorbidities that can lead patient to be at higher risk of AKI, and anemia, vascular disease are patient factor risk too. So procedure, as we have seen the slide before, is very much procedure dependent. So if the surgery is cardiac surgery, vascular AAA surgery, major abdominal surgery, or emergency surgery that can't be really planned, transplant, especially liver transplant, or any anticipated prolonged surgery, especially cardiopulmonary bypass is anticipated to be longer than 2 hours, or patient with having major blood loss. Exposure before the patient goes for surgery, the volume status is very important. Patient who are hypovolemic that goes for surgery obviously will get a higher risk of AKI. So preferably the hypovolemia is stabilized before patient goes for surgery. Nephrotoxic combination, so we have to review the checklist, any exposure of recent contrast, NSAIDs, aminoglycosides, and prolonged hypotension. So risk recognition should trigger a change in care. So when we see this patient pre-operatively, we should try to adjust what we can, but we should not also defer the surgery if the surgery is in emergency. So I think I mentioned in my previous slide, but just to highlight, so when we do a kidney assessment risk stratification, these are what we should look for. So kidney function, we look at the baseline serum creat and the baseline GFR. You do a urinalysis, better still, you have a urine ACR to look at the quantification of proteinuria, because if they have high level of proteinuria more than 1 gram, you can anticipate they are at risk of high risk of progression of AKI. And potassium, bicarb, electrolytes. And patient's physiological reason, whether the patient is anemic because oxygen delivery is important in surgery and also in preventing pre-renal failure. And volume status, if patient is hypovolemic or congested, both are at risk for AKI, and exposure of medication. So when we see the patient, we can actually estimate the risk, and from this we can discuss with our surgeon, or we can discuss with the patient and relative. There are some estimated AKI risks with their validated risk prediction models. I think you are probably aware of this. So in cardiac surgery, we have the TACA, META, and STS risk model, and in non-cardiac, there are some other models that can help to predict AKI and actually help to help us to re-stratify the patient, and then actually how we stratify is not the main thing, but what we do after we re-stratify is important. So when we re-stratify a patient, because we want to know whether they are at lower risk, moderate risk, or high risk. So then what we do with that? So obviously, if the patient is high risk, you probably want to prepare a ICU bed, and you want to prepare the patient should have an arterial line. You anticipate a longer surgery, and you probably want to look into AKI bundle religiously after the surgery, which I will mention. It is licensed to be given in patient with heart failure without diabetes. Yeah? So you probably see this, many patients are getting this. I think in Malaysia, we have already gotten SGLT to be widely available even in the primary care. So more patients will be on this. So it is very important to check if the patient is on SGLT2 before the surgery. SGLT2 is one of the side effects. It can cause euglycemic ketoacidosis, especially if the patient is unwell or hypovolemic. So the recommendation is we must stop SGLT2 before the surgery if this is an elective surgery. So we don't have ertugliflozin in Malaysia, I don't think so, but we have dapagliflozin and empagliflozin. So how many days you stop is 3 days before the surgery. It should not cause hyperglycemic to happen, because it is actually not a really good anti-diabetic medication. And then, the reason we stop is because we want to prevent patient from having euglycemic ketoacidosis, and this is recommended in AHA and ACC class 1 evidence. But it is not as direct AKI prophylaxis. Basically, if you stop it, you don't prevent the patient to get AKI, but you prevent the patient to get more severe acidosis should the patient have other complications of pre-renal or bleeding in the surgery. So the second medication is the nephrologist's favorite, RAS inhibitor. So RAS inhibitor is ACE inhibitor or ARB. So these are like your perindopril, losartan, temisartan, captopril. So basically, this is a very latest, a new publication just came out, JAMA 2024. It's a stop or not trial. So basically, following this trial, I think we have recommended not to routinely stop RAS inhibitor before the surgery. So we have to have an individualized decision for this medication. So contradicting to SGLT, you have to stop it. But for RAS, we have to assess the patient individually for their hypotension risk. So based on this trial, actually they randomized patient to the no RAS arm and RAS arm, and actually they found the incidence of post-op AKI was no different between the two arms when they stop it or when they continue it. But of course, there's a bit of hypotension in the continuation arm, but it was not significant. So the recommendation is we stop and withhold when the patient is having hypovolemia, hyperkalemia, hemodynamic instability, obviously, because it's a blood pressure medication, or active AKI where we think pre-renal is the cause. So usually in emergency surgery, definitely you need to stop it. Yeah? But if it's a stable surgery, even in cardiac surgery, sometimes they didn't stop it. But you omit 24 hours. if high hypotension risk, and then we can continue if the patient is stable heart failure, reduced ejection fraction, or compelling cardiorenal indication, because it is also a very good cardioprotective drug that may protect the patient from cardio side effects post-operatively. So, and the rest of the medications and exposure should be reviewed with the same balance or benefit with the perioperative harm. So, NSAIDs, we will always say avoid whenever possible. So actually, if you see a nephrologist, we will say NSAIDs is never, you know, but sometimes the patient may require, but use it with caution. But I would advise no NSAIDs if the patient has high risk of AKI based on the risk stratification. And aminoglycosides, some patients may have a very bad gram-negative bacteremia that would require your amikacin, gentamicin. So it is, I suppose we are supposed to continue that, but we have to be very vigilant on monitoring the levels, and we should avoid unnecessary coverage if it's not indicated. Basically, avoid empirical coverage and use other option if it's not proven to be sensitive to that organism. And obviously, the patient should not be on multiple concurrent nephrotoxin drugs that will put them at higher risk of AKI. And some medication may need some review or adjustment of doses like Bactrim, and then diuretics, metformin. Yeah? And all this must be documented in the checklist and in the plans so that it is clear. And also check the antibiotic dose to follow the Cockcroft GFR during preoperative surgery. So reduce avoidable nephrotoxins and medication-related dosing errors. So these are the pre-op checklists that you all are doing already. So P is prior AKI and proteinuria identified. R, we do a risk model stratification. And then assess volume status, ensure the patient is euvolemic and not in congestion. And potassium, acid base, hemoglobin to optimize if necessary. Avoid nephrotoxins, stop what is needed, and the documentation, whether you want to continue RAS or you want to withhold, should be documented so it is clear for the nurses. And after we re-stratify the patient, we should plan whether the patient needs escalation post-surgery, whether it should go to ward, HW and ICU. For a patient with high risk of AKI, they should go to ICU for better care. And most important, do not postpone the emergency surgery if this checklist doesn't meet our criteria, because if the surgery is life-saving, we should do what we need to do. So now we go to identifying vulnerability to protect the kidney intraoperatively. So, yeah. So intraoperative protection is fundamental, basically maintaining effective hemodynamic perfusion throughout the procedure from induction, intubation, and until patient is extubated and planning to transfer to ICU. So this basically there are 5 intraoperative priorities that I've classified here. It is from maintaining a good blood pressure, MAP, circulating volumes, cardiac output, oxygen delivery, especially in cardiac surgery, venous pressure, especially in intra-abdominal surgery or in surgery where they do laparoscopic, they probably pump a lot of air, and metabolic and nephrotoxin control intraoperatively. So this I will go through briefly these 5 priorities in bit detail. So first is the arterial pressure. So we should avoid intraoperative hypotension as much as possible, because studies and data have shown that even a 10 to 20 minutes of profound hypotension may increase post-op AKI risk. So so assess fluid responsiveness before we need to give fluid, because because I'm sure you know that the Starling law, yeah, even if you are hypotensive does not mean we are fluid responsive, yeah. And apart from remembering hypovolemia can risk AKI, the contradictory also true. Fluid overload and hemodilution may also worsen AKI. So we should find the balance in the surgery to get in between. There are some recommendation we can probably consider goal-directed fluid therapy if we need to administer more fluids after the first bolus when the patient at first episode of hypotension intra-op. So generally, what's the MAP we target? Generally, evidence, based on evidence, I think, and guidelines, MAP more than 65, but we may want to individualize this according to the patient criteria. We may consider a bit higher MAP in a patient with chronic severe hypertension with altered autoregulation or any cerebrovascular stenosis that might require high MAP to perfuse the brain, or ongoing kidney hypoperfusion despite MAP more than 65. This is especially in kidney transplant recipient post-operatively. They may require slightly higher MAP post-surgery to maintain the perfusion, or in patient with a persistent low diastolic BP. But those are individualized, but in general, more than 65 should be acceptable. So just to share, this is a sub-study of the POISE-3 RCT that look into perioperative hypotension avoidance strategy versus a hypertension avoidance strategy on the risk of AKI. This was published in 2023. So POISE actually is a study in tranexamic acid using perioperatively in bleeding, but then they do a sub-analysis of the data looking at the blood pressure. So in this sub-study, basically they put the patient in two MAP target. One is more than 60 and the other one is more than 80 intraoperatively. And actually they found that there was no difference significance of AKI even if you target a higher MAP. And this is a large RCT, I think involve thousands of patients. So I think based off this it is sufficient to be safe. Target more than 65, because if you target higher MAP, we have to also we have to weigh the risk and benefit of the high vasopressor or high fluid loading that may be detrimental to the patient. So if a patient is having intraoperatively hypotension, especially after associated vasodilation, either sepsis, analgesic agent, propofol, So default resuscitation, fluids. So which type of fluids? So I think until today, the evidence more of balanced crystalloid, and I think we all have been doing this, but just to add on here, maybe for the junior doctors, these are the obsolete thoughts that we should put away. So basically, we don't use any more starch or albumin just for renal protection. Yeah, and then of course, obviously, if the patient is having blood loss, it's not crystalloid. If you have blood, you give blood. Yeah? Okay, this is when there's major active blood loss, repeating everything with crystalloid is also inappropriate. So in OT, and we always have GXM, so we have to plan the blood appropriately. So talking a bit on relief trial. So basically, we talk about what type of fluid. Now we talk about how much of fluid. The amount is equally important. Aside of the type of fluid that we want to give. So relief trial is actually strategy. They look into liberal fluid strategy versus restrictive fluid strategy to be given in a patient who's having intra-abdominal surgery and the risk of AKI intraoperatively. So they actually found that basically there is a slight if you see here, the primary outcome is just it's not to see the kidney, but the safety and secondary outcome. There is they look into risk of AKI and also elevated need for RRT. So in the restrictive group from relief trial, they found that the patient is on restrictive. Basically, you restrict the fluids. They get higher risk of AKI compared to those on giving liberal fluid. But actually, if you look at this study, so we had a discussion on this paper. So actually, when you look at thoroughly at how much fluid they give, even though they are restrictive, even though they are liberal, they are not too liberal, basically. And actually, in the two cohort, they are the liberal actually they actually don't give too much fluids too. So basically, I think anesthetists in intensivist, we are already trained to watch how much we load the patient. So based on this study, basically it's recommended if you have an intra-abdominal surgery, you probably want to give the patient a bit of positive kilo post-surgery, but just remember, liberal does not mean unregulated. It doesn't mean that we can pump a lot of fluids. So, and obviously we should not avoid this positive 1 to 2 kilo in a patient with severe heart failure, RV dysfunction, or established venous congestion. Yeah. So again, we have to individualize. So I always tell my fellow, when we read papers, we have to look at the tiny things that they produce. Yeah? So in a nutshell, how much fluid you want to give. So we should not give that, we cannot, because we know that both extremes can injure the kidney. So too little fluid may cause problem, but too wet also cause problem for the kidney. So how do we get to the therapeutic target? So in this case, probably some hemodynamic monitoring of fluid responsiveness is probably important to get this therapeutic target, so that we get to this balance zone to protect the kidney intraoperatively. So in KDIGO AKI draft 2026, based on the evidence available, so they recommended in major abdominal surgery, favor mild positive balance, about 1 kilo, 1 to 2 kg at the first 24 hours rather than restrictive. What about cardiac output and oxygen delivery? So I'm not going to talk very much detail in this, but just to highlight that oxygen delivery is whatever the arterial oxygen content and the cardiac output to the kidney. So for the kidney, basically enough cardiac output, you get enough oxygen, So, and you need this forward flow basically. So apart from getting the MAP right, we also have to get the oxygen content right. And that brings us to, so basically check your MAP important, and this is important in cardiac surgery bypass, where we can monitor the DO2 to check how much we deliver to the patient. Venous pressure is the next important thing that we should check intraoperatively. High venous pressure, we know it reduces the effective gradient across the kidney because to get AKI, it's either you have reduced forward flow or you have a backward congestion back to the kidney, because kidney is an encapsulated organ. So if the outside environment is congested, the pressure in the kidney will be high, and this will cause reduce in GFR and AKI. So how do we monitor? So the pressure in the kidney very much depends on the intra-abdominal pressure. So intra-abdominal pressure is your MAP minus the pressure in the kidney is depending on your IAP. So IAP is basically it's MAP minus your CVP, but if you can monitor the IAP, if the IAP is higher, you will take the IAP. So and then when to measure, we don't measure in everybody, but we probably will want to consider measuring in a patient with very tense abdomen, very tense ascites, and then patient who had very massive blood and fluid resuscitation and eventually became oliguria, because this volume will just go into the third space. Yeah? And patient with unexplained oliguria or increasing vasopressor support. So intra-abdominal hypertension is defined as sustained IAP more than 12, but if the level is more than 20, it is already abdominal compartment syndrome. So in this situation, the patient will usually get a new organ dysfunction, and this includes AKI. So we have to do everything that we should to reduce the IAP. This is the probably the forgotten part of AKI, because traditionally we always like to supply the MAP, but we forget the backward when the kidney is not functioning. And in laparoscopic surgery, the gas that being given also can give some contribution to high intra-abdominal pressure. So they may need a decompression immediately after the surgery. So in surgery, sometimes the patient may run into hypotension or transient oliguria. So So this is, I'm sure you all know, but the thing is, not every reduce in renal function, not every reduce in urine output needs a bolus. Okay, so a fluid bolus may increase urine output, but it will not prevent kidney injury too, and it may worsen congestion, especially if the urine output does not match the bolus that we give. And routinely giving furosemide is also not advisable, just to reassure the urine output number. The kidney will always do what they need to do when the time comes, and you do not want to be giving this intraoperatively where it can induce more hemodynamic disturbance, especially if you don't have proper hemodynamic guide on patient fluid status. And our final intraoperative priority is preventable of avoidable metabolic and toxic stress, and this includes sugar intraoperatively. So the latest KDIGO suggested 7.8 to 10 millimole perioperatively, but the ADA, I read the ADA wants a tighter level, 5.8 to about 8. Yeah, but basically we have to prevent hypotension. Yeah, and then exposure, I don't think we give all this intraoperatively, but antibiotics may be given, so just check antibiotics is according to the GFR before it's being given. Temperature monitoring is important, and should avoid hypothermia, and this is especially during cardiopulmonary bypass, and also the trend. So one reading is probably doesn't tell us much, but the trend is very important. So the trend of the lactate, the trend of the bicarb, the trend of the glucose should be monitored, especially the prolonged surgery. Yep. So just to put down there, no renal protection role in. So there's no role to give a dopamine intraoperatively just to put the blood pressure up. Mannitol during cardiopulmonary bypass has proven no benefit, and diuretics do not prevent AKI. So these are class 1 evidence. So I think we should avoid doing this unless there are other indications. So patient has gone into the surgery. So now is a post-operative time where whatever has happened intraoperatively now will evolve post-operatively, or it may happen after the surgery. So what most important post-operatively is how we detect early. Yeah. So post-operatively in those high-risk patients, we should have more vigilant surveillance to detect evolving AKI early. Yeah. So the same thing, you monitor the perfusion volume closely and monitor the urine output trend, have a serial creatinine and electrolytes, and interpret serum creatinine with patient's fluid balance, because the creatinine may not rise first because it is a delay marker in AKI. Second, because the patient might have been given a lot of fluids intraoperatively that the creatinine may be diluted. So creatinine doesn't really tell us much, but urine output probably gives us a clue apart from biomarkers. And we look at the cause and exposure, check back drug doses and sepsis situation, and escalate if trajectory worsen. So who should trigger an intensified response? So this one I was just going to talk because there are some papers, there are some data on using biomarker post-operatively. So biomarker testing is obviously it's expensive, but we may consider it if we have it and we do it, and it may change the results. The results of the biomarker change how we manage the patient. So in a high-risk surgical patient, post-op biomarker has a role because when there are positive results, then we can activate this bundle, KDIGO bundle AKI. But before we have, so basically we don't do biomarker for every situation, but we may want to consider getting biomarker for a high-risk patient, because I think more growing data have supported using biomarkers post-operatively in certain population of patients. So this is the latest being published. I had the privilege to be involved as a sub-investigator in this study when I was doing my fellowship. So BIPAC2 is a biomarker-guided KDIGO bundle after non-cardiac surgery. So basically in BIPAC2, we enroll high-risk major surgery that is non-cardiac. And the patient, so we re-stratify the patient before the surgery, patient gets consented, and then And then post-operatively, if the patient is has a central line and has high risk of AKI, so a nephro check, biomarker nephro check was performed to the patient. So in those nephro check positive, the patient will be activated to a two arms, whether it's KDIGO bundle, hemodynamic fluid resuscitation arm, or the usual based on the preference of the anesthetic. So it is actually done in the recovery room in the OT. The patient is not in the ICU yet. So post-surgery in the recovery room, that's where we recruit and we randomize the patient. So they actually found, it was just published end of last year, so they actually found that there is a significant reduction of AKI stage 2 to 3, number needed to treat 12 to 13 in the patients who are in the KDIGO bundle arm, right? So what we do in the KDIGO bundle arm, basically the patient will have a PICO and in centers where they don't have PICO, they actually do anything to monitor the cardiac output. So there are some centers that do POCUS and measure the LVOT BTI after a passive lead raising test. So we did a passive lead raising test and then measure the cardiac output. So if the cardiac output is, if it's suggestive that the patient is fluid responsive, bolus are being given. If it's not, inotrope is being given. So it is done the first 12 hours post-surgery, and remarkably there is some significant reduction in preventing the patient to go into severe AKI. Yeah, so it suggests that targeted therapy actually has a role in combination with all the supportive care bundle. Yeah, so actually Big Pack actually arrived from many previous trials before. So it starts from Privaki. Privaki is basically a feasibility trial. It was done first by Professor Zabok in 2017. So it is a feasibility trial in a cardiac patient, looking at whether the bundle actually is doable. And after Privaki, they did a Privaki multi-center, and Privaki multi-center also has found that there is some significant reduction in KDIGO stage 2 to 3 AKI. P-value was 0.03. So following that, they actually do Big Pack feasibility trial, and that followed by Big Pack 2 feasibility trial. So based on these 4 RCT biomarkers, so I think it's probably enough at this point to tell us that biomarkers has a role, but it should be targeted to certain group of patients. We probably don't have much role in low risk patient, but it's probably, but if you do that, we must also have a objective hemodynamic assessment to look at cardiac output, because the KDIGO bundle needs to be done, and it is actually not easy to do passive lead raising and monitor cardiac output in the first 12 hours so frequent. But it helps in preventing boluses, fluid bolus when it's not necessary, and when it's necessary. Yeah, but just remember that biomarker positive does not equal to give fluid. It just identify patients who may benefit fluid by the hemodynamic assessment. And following that, I think in the recent KDIGO draft 2026, they have put there a role of biomarker when available in high-risk surgical patients. So for those who are in cardiac center or centers doing AAAs, these are probably higher risk patients that we probably want to consider. And these are done in the recovery room before the patient goes into ICU. So these are, so this is just to summarize also what not to do in the operating theatre. I actually just summarize what are the latest evidence, but I'm not going to go through detail, but what has been mentioned. So renal dose dopamine, do not use. Starch, HES, no role. Routine mannitol, no established benefit. Phenol dipam, not as general prophylaxis. So NAC, no routine surgical AKI prevention, no role of furosemide forced diuresis outside selected protocols, and we should avoid blind boluses for oliguria. And there is also no routine early dialysis if the dialysis is not necessary, just to reduce the creatinine before surgery. Tight glucose control is important, but always look at hypoglycemia risk. and fixed low dose inotrope with goal-directed fluid therapy. These are not done routinely, but may be considered in some cardiac surgery situation. So, and then therefore, I have just a short slide on cardiac surgery because I think it deserves separate attention because cardiopulmonary bypass introduced additional injury to the kidney apart from, from the usual stress that other surgical procedures. So these are the basically mechanism of cardiac surgery associated AKI, or better known as CSA AKI. So it results from all these four disturbance from the hemodynamic perturbance to mechanical factors during the surgery may induce some emboli, arterial obstruction, venous congestion, patient will be overloaded, and this cause perfusion pressure and abdominal hypertension. And in addition to that, other mechanisms like neurohormonal vasoconstriction, tubular toxicity, and inflammation during the bypass itself. This complexity explains that why no single intervention actually has been proven to prevent AKI, but you need to control of all these factors. And especially during this, during bypass, several of these mechanisms became more enhanced, So, so these are additional injury in cardiopulmonary bypass. There will be exaggerated inflammation because when you do the bypass, there's more cytokines will be released, and it causes hemolysis, especially if you do ECMO intraoperatively. Low float states, obviously, the patient with poor cardiac output, and then on pump. Embolization, hemodilution, venous congestion, temperature, and duration of the bypass itself. So during bypass, there are some literature. This probably best being referred to the cardiac intensivement study. So it is not a randomized trial. So the center actually do a GD, goal-directed resuscitation, and then the protocol actually assessed malperfusion, reduced MAP, reduced forward flow, and congestion, and they test with fluid responsiveness. So this is something like what the biomarker study does, but they actually look into the delivery of oxygen. And the results support patient, they actually managed to, they found the patient has a reduction in AKI, but the AKI is defined by the rifle criteria from 12% to 7.8% in patient with who had the goal-directed resuscitation plan. So this is something like BPAC, like what I just mentioned, but this is intraoperatively in the surgery, right? But because it's not an RCT, so they can't recommend this as 1A criteria. This is just an audit for that center who has been doing it. But it may be something that I think probably we have been doing. But most important, the take-home message, there's probably some role in protocolized physiology-guided resuscitation to reduce mild to moderate AKI. So this study does not actually prevent dialysis. It just reduces on the mild to moderate stage 1 to stage 2. So another evidence for cardiac surgery comes from protection trial. So this is role of intra-amino acids for kidney protection. So the protection trial actually randomized about 3,500 patients involving 22 centers. So basically amino acids is being randomized to saline. And then that's the dose that's been given. So basically, the mechanism postulated that amino acid will increase renal perfusion and recruits renal functional reserve, and it aims to reduce incidence of ATN and also AKI. So the outcome, there are a lot of amino acid studies before, but this is probably the largest RCT that was just completed. I think it was just published 2024. So from this, it shows that it actually modestly reduced AKI from 31 to 27%. But it is strong towards a severe AKI. Okay, and but however, the requirement of dialysis mortality were not different. So it may suggest some role, but it may not. But it should not be put as priority as yet. Another new, I mean not new things, but another thing that being mentioned in cardiac surgery, so it's remote ischemic preconditioning. So this is as other proposed adjuncts. It has actually less consistent evidence, but it may have some role in the future if it has more RCT being done. So so far, I think the evidence comes from a small center study where they do a remote ischemic preconditioning. Basically, how they do it, they actually put a BP cuff in surgery. This is also done by Professor Zarbok, I think quite a long time ago. So they put a blood pressure cuff and then they inflate the cuff up to 200 millimeter mercury. And then it was done every 5 minutes for about 12 times in the operation. So basically, you induce hypoxia to the organ. So because they put, when they do in animal studies, they found that hypoxia actually can protect the heart. So basically, the mechanism is that when you reduce in this surgery, you know, the blood flow to the kidney will bring all the cytokines, right? So when you stop delivering the cytokine, you may protect the kidney. So that's what they postulated. So actually, but this is a very small center, but they found that there may be some role in that particular trial, that it reduced organ injury and especially AKI, but this study failed to be replicated in a larger population. So just remember, if you read this, it is not a consistent evidence, but in a CKD population, this theory is the evidence is vast. You know, in end stage patient, there is a medication where it induces hypoxia to the kidney, and then actually it helps the kidney to get more hemoglobin, so it protects the anemia. But it does not translate this hypoxia in AKI at this point. Okay. So what about role of extracorporeal blood purification and AKI? So I think by far this is probably the largest this is about Siraki 2 is about use of auxiliaries intra cardiac surgery. So it is actually by far probably the most highest number of patients recruited in an auxiliary study is about 300 patients. So you know, when you do all this extracorporeal RCT, they actually don't have a lot of patients, so that's why the data should be read with caution. So this by far is the largest, probably 300 patients. They randomize the patient to getting auxiliaries during the cardiac surgery when they anticipate the surgery is going to be prolonged more than 90 minutes. So they start using the filter from the beginning of the surgery, and then the filter is terminated towards the end of the surgery, so the patient is not continued on CRRT in the ICU. So auxiliaries has actually shown that there is a reduction in AKI at 7 days, but there's a lot of confounding factors in this paper actually. So just to highlight that this is probably promising, but basically it is hypothesis generating because they do not sub-analyze other factors that probably has been taken care to prevent the AKI. So I hope there's no ventive people here, but just to highlight, you know, when you read a paper, you know, you should know that how they analyze it. So we don't buy it that, oh, then every patient must have an auxiliaries intraoperatively, you know. So what happened? So we've talked about perioperative protection. So what happened if the AKI is already established? So goes back to the same concept. Assess the fluid status, give fluid only for volume responsive hypoperfusion. So I hope you all know what is meant by volume responsiveness. So it does not mean hypotension, does not equal to volume responsiveness, nor dryness. Volume repletion also does not always equal to volume responsiveness. So volume responsiveness means any situation that the patient will have an increase in cardiac output, about 12% after volume is given. right? So usually how to test, you have to test the cardiac output monitoring, right? And diuretics are used for clinical significant overload, but not to treat creatinine or to convert oliguria from oliguric to heavy urine, right? And role of kidney replacement therapy, start for the conventional indication, obviously, but you may also want to consider in a patient where we have pumped a lot of fluids that you may want to get a fluid balance, right? We do not want to wait until they get pulmonary edema, then only you want to dialyze them, right? But most important, do not initiate dialysis just because the creatinine has crossed some baseline. You know, sometimes we get some questions, you know, the creatinine now is 250, we want to refer for dialysis. So we do not dialyze based on the creatinine because it will not change anything. The creatinine will come down, but if the patient has AKI, it will just go up again. And creatinine should not be something dangerous, but other things are dangerous. You know, the creatinine is not a toxin, right? But other things may be toxin, and those are the things that we look at. So just to put a bit, since there are actually large evidence saying that patients with AKI, they are at risk of CKD, even if the AKI actually recovered. So I'm just putting a bit of slide on kidney recovery should continue monitoring even after discharge. So, so if the patient is in ICU and the patient had AKI recovery, please remember to put the AKI diagnosis in the ICU chart, right? AKI recovered to baseline, AKI dialysis dependent, AKI improving but not recovering. You know, put a diagnosis so that when the patient is being transferred to the medical ward or the surgical ward, they are aware that the patient has had AKI, because this is important. Obviously, if the patient is on dialysis, they will go to nephrology, so we will take care of this patient. But the patient that was in between may be missed follow up. And no, because the patient may have AKI that may not require dialysis. You've had a good fluid resuscitation, the creatinine peak at 300 and then goes down to 200 and then out of ICU. You know, if this is not put in the problem list, there is some concern that the patient may just be discharged to primary care and nobody is going to monitor up to what level the AKI will recover. Yeah, so. And all patients with AKI should have a reassessed kidney function and markers of damage at 3 months. This is KDIGO criteria. It does not mean it has to come to nephrologists because there are only few of us, but obviously it needs to be monitored by either primary care or physician. So this is my last slide. Not obviously last, but my last educational slide. So I think it's probably a bit. I'm glad that I can see the eyes are still wide open, but just take home message, you know, for renal protection, there is no one thing that can protect the kidney, but it's a AKI KDIGO bundle. So be familiar with this term, because this is a term that actually it's been there since 2012, KDIGO AKI being produced, but it is not being oftenly talked as a bundle. But I think if we remember KDIGO, if we teach our junior, you know, have you checked the KDIGO AKI bundle? So if you look at KDIGO, it's a nice infographic, what are the bundles. So I think if you just go through this checklist, we probably can help our patient not to progress into AKI. It's actually the very thing that we do, but sometimes, especially junior doctors, they just need a checklist because there's so many things that they have to do. But if you have a checklist, you know, they can just go check, oh, I've checked the volume, I've checked the PS, especially the PS. Don't leave the patient without seeing the PS. I've checked the sugar. You know, sometimes juniors may just check the creatinine, the urine output, or sometimes you may just check the ventilator or the oxygen or the bicarb. We just forget to check other things. So if you have a checklist, it is safe for the patient and for the practice. Just to highlight for contrast, we would still say avoid if it's unnecessary, but contrast is not something that, there are more evidence that saying contrast is not something that the culprit for AKI, but so they have changed the terminology from contrast-induced AKI to contrast-associated AKI. So it is also the same. The contrast per se, because I think the contrast that we use in the country is the low osmolar, the best contrast that can reduce AKI. We don't use the high osmolar contrast, you know. But obviously, if the contrast is a lot, it can give high risk of AKI. And in what situation contrast, there's a lot of contrast being given, is usually in angiogram. But the contrast for your CT scan is actually very little, right? But so the contrast in angiogram, when the cardiologists had difficulty to find the blockage, they have to put a lot of contrast. These are the higher risks for AKI. But the contrast for the scan should be safe, provided the patient's other factors are also optimized. The patient is not hypovolemia, the patient is not congested. So we have to minimize all the other risks that is associated with AKI to prevent the contrast-associated AKI. So we should not defer a contrast image if it's going to save the patient, even though the patient has AKI, nor we should dialyze the patient preemptively after the contrast to remove the contrast, okay? Because the contrast are dialyzable, but if you want to dialyze the contrast, you should dialyze it when the patient had the contrast in the CT scan. So that's why. So it's dialyzable, but there's no rule to dialyze it after the procedure, because whatever you do after the procedure, the contrast has set in the tubules already, so it can't be dialyzed anymore, right? Okay, so that was my last slide. So I'm just going to take this opportunity to invite all of you. So next year, 2027, we are privileged to host World Congress of Nephrology in the country. It will be in KLCC. So can take a while and scan the QR. So we actually encourage abstracts. So the abstract submission is 20 October, but all abstract will be published in Kidney International. So you may want to get your work being recognized. And if you have not registered ASMIC, so we will be in the pre-congress workshop. We'll talk about fluid management. I think there are still some slots, so maybe you want to go to ASMIC Facebook and check it out. So with that, I thank you.
Okay, thank you very much, Dr. Nurul, for such an insightful presentation. I believe we have gained valuable knowledge about renal, perioperative renal protection. We can adopt it to our daily practice, right from our pre-anesthetic clinic. When we re-stratify the patient, we optimize patient blood sugar, hemoglobin. We reviewed the patient medication, what to withhold and what to continue. Intraoperatively, we prepare the patient which need accessory monitoring, keep the patient euvolemic, maintain the blood pressure, maintain the cardiac output, and post-operatively, we monitor urine, creatinine, urine output, and follow up those patients who are developing AKI pre-operatively. Now, from kidney, we move to the heart. Okay, it is my turn to introduce you to the next speaker who is equally distinguished. She is Dr. Fazwani, an anesthetist in Hospital Kuala Lumpur. She obtained her specialist degree in UKM. Then she pursued her fellowship in perioperative medicine with special interest in thoracic anesthesia. She is currently the president of Nation Perioperative Medicine Society, and she is actively promoting pre-operative optimization, patient blood management, and also ERAS. Today, she will be presenting anesthetist's role in MINS, myocardial injury after non-cardiac surgery. Without further ado, the floor is yours, Dr. Fazwani.
Thank you, Ms. Chairperson, for the very kind introduction. Let me just test this slide. Okay, let's go back. Okay, the given topic is anesthesiologist roles in MINS, but somehow I actually tweak a little because the AI told so, and I find it very interesting. Okay, so it's about still about MINS and perioperative management. to begin with, definitely anesthesia has a big roles in managing and preventing MINS. Okay, so I couldn't remember actually the last time I came to Bangi, so very pleasure to be here today, and thank you to the and congratulations to WSAC for organizing second WSAC. Okay, let's begin. I have nothing to disclose. Okay, so these are my content for my presentation today. I would like to thank Dr. Zaina for her comprehensive review about preventing AKI. So it's definitely similar concept. Same concept. We'll be talking about understanding the risk, and then the risk assessment, how to stratify the risk, identify the risk, who are at risk, and then what will be the risk reduction strategies, how to mitigate means during the perioperative period, and then we'll be talking about biomarkers. There will be a lot of biomarkers rolled in this topic for means today. Okay, so let's begin with the MI definition. I think in the old days, not sure how we define how old, but when we say MI, would it be myocardial infarction, myocardial injury, myocardial ischemia? Okay, so with the topic today, we'll be focusing on the myocardial injury after non-cardiac surgery. Okay, that's why the abbreviation for the MINS. But before we come to that, so the definition that we need a definition to make a diagnosis. The definition has been probably proposed as early as in the late 1950s by WHO. And but what we know actually until before 2018, we were told that there's only one definition for the myocardial infarction, which is the raise of the troponin and presence of one of these symptoms. One of these symptoms is either presence of the clinical symptoms of ischemia, the ECG changes, whether ST changes or the Q wave, and any presence of the abnormal regional wall in the echo or presence of thrombosis in the coronary angiogram. But however, so since 2018, we have moved into deeper classifications or like a very strict definition, starting with identifying myocardial injury before the myocardial ischemia happened, before the presence of the myocardial infarction. Okay, and why the American Heart Association make these definitions more strict? Okay, because the myocardial, before we get a myocardial injury, there will be the physiology of the myocardial injury. So detecting myocardial injury is very crucial. Okay. So basically, this is the fourth universal definition for myocardial injury. It has to start with the raise of troponin alone. Okay. So whether now when we talk about troponin, I'm not going to talk about the whole detail of whether which one is better, troponin I, troponin T. But we're talking a lot more about troponin T. But I would like to highlight about the difference between the conventional troponin and the high sensitive troponin. Okay, what's the difference? So the difference with the new, I would consider to say that we have a new biomarkers of troponin, which is a high sensitive troponin. Okay, the high sensitive troponin is more sensitive, okay, hence the name, and it has higher negative predictive value compared to the fourth generation troponin, which is the normal cardiac troponin. So depending on the type of the assay, the lab, okay, the type of what kind of the brands of the lab that we the hospital take. So basically, the high sensitive troponin could detect as little as 12 nanogram per liter as compared to fourth generation troponin, which only detects at the higher level. So as low as 12 million, so it could detect myocardial injury. Okay, so it means that it can detect early way better if there something happened to the heart. Okay, so hence, so with this consider new development, new technology, so it has been proposed that high sensitive troponin T is a good biomarker to detect myocardial injury. Okay, what we can say the difference is like, so at this stage, when the cardiac troponin, the conventional cardiac troponin have a raised value, the patient probably already started having a component of ischemia and infarction. But however, if we send a high sensitive cardiac troponin, so when the level is reaching more than 12, entering the orange zone, so that means that the myocardial injury is started to happen. Okay? Okay. So why is understanding means is important? Because means is actually a silent killer of a myocardial injury. Because it doesn't come with symptoms. When we talk about the definitions, it's only about the raise of the cardiac troponin. So that means that if we don't send the cardiac troponin, either the conventional or the high sensitive, so we won't know if patient started to have a myocardial injury. Okay. The vision study has looking at the association of the post-operative high sensitive troponin levels and the myocardial, with the presence of the myocardial injury and the risk of the 30 days mortality among patients undergoing non-cardiac surgery. And they found that the higher the values is the higher the risk, up to 30% of risk of death. So basically, when we're talking about the risk, anything more than 5% is considered high. Okay, now we proceed with the risk assessment. So the risk assessment, I like to take the reference from the 2024 American Heart Association. So they provide a very comprehensive preoperative assessment for patients undergoing non-cardiac surgery. Okay, but I like to divide this assessment to make things simpler, okay, more practical, especially in the preoperative period. Is so the step one is look at the timing for the surgery, okay, and the next is the risk assessment, which includes surgical risk, patient's risk, and assessing functional capacity, and then where is the roles of the biomarkers to stratify the patient and maybe plan for the next interventions. Okay. Okay. Now, before we move to the whole risk assessment, I like to talk about the echocardiography. I'm pretty sure that it has been done routinely. When we think patient is high cardiac risk, we would immediately, it's like a reflex, or the echo. But I would like to emphasize your routine resting echocardiography does not actually change patient's conditions or perhaps much of our management. Okay, it doesn't prevent patients of getting means. Okay, because most of the time, according to Allison, in her study, she found that 1/4 of the patients who had a preoperative echo was considered inappropriate. Inappropriate in the sense that it's actually patients in the considered stable heart failure or ischemic heart disease that actually doesn't change any patients of the clinical status. And for this study by Vijay Sundra found that there is no difference if you do echo in improving 30 days mortality, because when patients have a resting echo, they can present it with the normal ejection fraction. And then if we see a normal ejection fraction, we tend to not treat them or monitor them carefully. So hence, there will be no difference. So according to the AHA again, referring the 2024 guidelines, the only reason why you should order echo probably urgently is when there's a change, there's a presence of murmurs during the examinations, okay? Whether you want to look for valvular stenosis or regurgitation, and presence of new dyspnea, short of breath and exertion, or worsening dyspnea for patients who already don't heart failure, then you want to do echo to look at the progress of the disease. Okay, but in practicality, in my setting, in the anesthetic clinic, I would also consider the RCRI score and any abnormal ischemic ECG patterns. Okay, now this is the most important part. So echocardiogram is not the only thing that can risk stratify your patient, whether they're going to be at risk of myocardial injury, infarction, and ischemia. So there are a lot of other ways to risk stratify, to support the risk, and to help with the discussion with the family and the patient. Okay, so other than understanding the surgical risk means like whether the surgery is minor, major complex, or complex surgery, or whether is it in the emergency or the elective. Okay, so each the more complex the surgery, definitely is the more the higher the risk. Okay, regardless of the patient's conditions. That's already have major complexity already have quantified more than 5% of the cardiac risk. Okay, because of the nature of the stress response surgery. And then this is what we normally know. We've been taught about the risk assessment, patient risk assessment. Okay, we'll go about this in the next slide. And then assessing the patient functional capacity using the MAT scoring system or DASI. We'll go through about this in the next slide. And the importance of the biomarkers. Okay, so these are basically the summary, a very nice summary taken from the 2024 AHA guidelines. The summary of a risk scoring system, the calculators. Okay, each of these, they are not all. It's not only to identify the risk scores for cardiac, but also give you the risk, predictive risk for 30 days mortality of all causes. Okay, so what we already know is the RCRI, which was established and validated in 1999. Okay, it's quite simple. It's like 30 seconds calculations. Okay, however, the problem with RCRI is definitely detecting the risk of patients getting thrombosis, okay, ischemic, but it doesn't tell, and the components that they are taking into the measure is mainly the presence of the ischemic heart disease, the presence of previous stroke, heart failure, diabetes status with the insulin, the kidney status. So, but it doesn't have the component of valvular heart disease or the arrhythmia or patients with presentation of AF. So this would require a different type of risk assessment. Okay, so but other than the RCR, I actually like to use the American College of Surgeons, NSQIP. Okay, which was produced in 2023. Okay, it has more comprehensive. It takes into account patient physiological factors, okay, and the type of the surgery, and some of the medications, including the steroids. Okay, so it may take a little bit more time to actually key in and get more information to calculate, but it produces other than the risk of the myocardial adverse events, okay, the myocardial injury itself, MI, and the stroke. It also gives you the predictive for the 30 days mortality risk and also some other post-op complications. Okay, so now we're moving into the functional capacity assessment. It's basically about assessing patients' functional status. Okay, exercise capacity. So I think like most of us are familiar, definitely familiar. It's like a bread and butter that we test. We ask patients, basically subjectively ask the patients how much they can actually climb the one flight of stairs. And if they do, we simply say that their maths is actually equivalent more than 4. Whether, okay, is this one question is enough to quantify their effort tolerance? Okay. There's another, I hope that everyone's also familiar with the DASI scoring. Okay. DASI scoring comes in a set of questions that you need to go through all, okay, to engage about patient actual exercise tolerance. Okay. And each question has a different scoring where you will add up, okay, in the end to get the actual maths. Okay. So just bear in mind that walking around the house, moving just around the house, doing house chores does not equate to maths of more than 4. Okay, if we are comparing using the DASI system. Okay, so from the DASI, anything score more than 34 is considered good, and less than 34, you can safe to say that the patient is having poor functional status. Okay, so if we translate this, so using the DASI scoring system, you can actually count patient actual maximum oxygen consumption. Okay, the way to actually the gold standard way actually to measure VO2 peak, okay, is actually we need to use the cardiopulmonary exercise stress test. But that test is very comprehensive, highly requires a lot of technical stuff and require experts. Okay, so by utilizing DASI, it can be done in the anesthetic clinic and you can predict what will be the patient VO2 max. Okay. So let's say if we take, for example, a scoring of 34, just borderline. So when we extrapolate the DASI score into this calculation, it will give us actually maths of 6.9. So technically, to say that the maths that we know more than 4 is actually not a good enough to say that patient is actually fit for the operation, fit for the major surgery. Okay? Okay, next. So we're moving about into biomarkers. We talked just now about high sensitive cardiac troponin. It's high sensitivity as opposed to the conventional cardiac troponin. So cardiac troponins mainly is just a biomarker to identify there's some insults in the myocardium. Okay, but there's another biomarker which is called nitropeptide, either BNP or proBNP as a newer version. Okay, it detects how stressful the myocardium work. Okay, it's in heart failure clinic, it's quite common they do this test in the clinic as a point of care testings to quantify the patient's level of degree of heart failure. And this routine testing at the heart failure clinic can be actually extrapolated and be also recommended to be used in the pre-operative settings, where maybe when we found patients who have poor functional status, having failure symptoms, other than ordering echo, we could simply just order the BNP. Okay, so The values of more than 100 nanogram per liter may indicate that patient has heart failure and at risk of getting further myocardial damage. Okay. But these tests, like Dr. Zainah mentioned, cardiobiomarkers is very costly. Okay, so in HKL, we don't have this as a routinely for preoperatively. So the budget comes under the cardiology department. If we are to request this, so we have to go through them. So far, the use of these biomarkers are strictly for the patient who is known heart failure or patient that we think that going to change the management. Okay. So now we know that the patient is at risk. So what can we do to reduce the risk or to mitigate means from happening? It's definitely a multidisciplinary approach because from the start, let's say from the surgical clinic, surgeon should start should start talking to the patients by counseling the patients, starting with as simple as lifestyle modification of stop smoking. Okay, and then at anesthetic clinic, we do the risk assessment with or without a biomarker. We ask the patients about their assessing their functional capacity. So the scoring, the RCRI score, together perhaps with the DASI score, we use these scores to talk back to our patients to inform about the risk. Okay. And then, of course, at the same time, we will take the opportunity to optimize their medical health, optimizing their diabetes, their hypertension, and also planning for the procedures. Okay, Dr. Zainah has talked about poetry in her comprehensive lecture just now. I don't need to dwell much, but basically, other than this poetry, so they use the same data, not only to look at the risk of AKI, but they are also looking at the risk of for the myocardial injury. Okay, so if you could still remember about the trial that Dr. Zainah mentioned, they divided the patients into two type of groups, which is hypotension avoidance and the hypertension avoidance. Okay, so the one in the hypotension avoidance is basically the one that they targets the MAP of higher MAP, okay, because simply a patient who is known hypertension and they try not to get the MAP lower than 80, and at the same time because of the preventative measure of the hypotension, so the protocol was involved with the withholding of the antihypertensive medications, okay, and with opposed to what we called possibly the standard of care, where targeting MAP of 60 and but with continue all the antihypertensive measure. So either or of these interventions, it does not actually change the outcome for the, it doesn't reduce the risk of MIN. Okay, so what we can learn from this study is, so basically in avoiding intraoperative hypertension or post-induction hypertension is crucial, but there is no one single number to safe to say that this is acceptable. Okay, this could be no single number can be determined to reduces the risk of MINS or AKI. Okay, so AHA, however, nevertheless, AHA is recommended that whatever the baseline, that we think is suitable for the patient, okay, based on the assessment, we should never drop the blood pressure more than 20%, okay? But certainly anything, if the blood pressure drops below 65 or 60, that can be considered as ischemic danger zone. Okay. So for this, the direction would be possibly use a advanced hemodynamic monitoring, advanced cardiac monitoring, optimizing fluid and oxygenation, and then be vigilant or be do not if you remember Dr. Zana mentioned about the role of inotropes, we have to be balanced about introducing inotropes and vasopressor just to keep a certain MAP or higher MAP, because that will impose to the other risks as well, and it doesn't help with the reducing of means anyway. Okay, this is what the POCI has been recommended. It was published in 2019. Okay, although it's mentioned here, it was recommended that to hold RAS inhibitor, the antihypertensive, the perindopril or valsartan, 24 hours before surgery. But with the newer recommendation, like Dr. Zena mentioned in 2024, it has to be individualized. Okay, patient with stable heart failure, what more stable, unstable heart failure, there will be more cardiac protective benefits by continuing RAS inhibitor. But the rest, like loop diuretic, should be individualized, and we shall continue the amlodipine, the calcium channel blocker, as well as patients who are already on beta blocker. Okay, but one thing that we continue to highlight is there is no single blood pressure value to define the target, so it has to be individualized. Okay. Now, what about anesthesia and analgesia? It has to be balanced. Okay. TIVA and inhalational anesthesia, both are cardiac suppressants drugs, but it has to be balanced. Okay. And pain. So anything. So whatever we do. The balance anesthesia is basically meant to reduce the stress surgical response. So minimizing the is technically reducing the heart rate, reducing the sympathetic state. It's actually protecting the heart. Okay. Other than that, so other than be vigilant about the blood pressure monitoring, having a balanced anesthesia, anemia is also known to for its risk to have means. Okay, sorry, say that. Okay, so in this study in the Korea, it was recently published, maybe in 2021. Okay, it found that patient with anemic has a higher risk of getting MENS by odds ratio of 1.57. Okay, and the odds ratio is continued to raise in the category of the moderate to severe anemia. And surprisingly, even the threshold of 12.2 is already an indicator of risk of patients getting MENS. So this anemia, so in our practice, can be identified as early as our pre-op assessment, isn't it? So now that our patient blood management, we have been advocating about optimizing anemia before surgery, especially in the elective setting. So for HKL, we've been advocating to screen and treat iron deficiency. Although if it's given correctly in time, it may improve the hemoglobin. Okay, but however, optimizing the iron storage itself, it actually can improve patient outcome. It provides the cellular energy for patient, especially going for high risk surgery. Okay, and then we also been advocating to use the tranexamic acid. okay, in all high-risk surgery. Actually, there's a different slides. I added hemoglobin threshold. The restrictive transfusion still applicable post-operative, even patient who are at risk of uh, high cardiac risk, with the threshold of down to 7, provided patient remain asymptomatic, hemodynamically stable. Okay, but however, if we suspect patient to have means when there's a raise of the cardiac troponin, okay, so the threshold could be raised to 8. Okay, I was given information that the time's almost up. Okay, now post-operatively, there's no other way safety net than doing a surveillance. Although, yes, biomarkers is expensive. So if I know my patient's high cardiac risk, although I can extubate and send patient back to the ward, I always given standing instruction to the surgeons, okay? To please, before cardiac markers, I used to say, please do your ECG every day for 3 days, and please look for any changes, and then refer to cardiologists if there's present. But now, I also consider to include cardiac troponin on top of the ECG for 3 days after the surgery. Okay, so what happened if we found that the patient's suspected myocardial injury? So the diagnosis of myocardial injury is basically we need to have the baseline and check the change of the levels in the next 12 hours or 24 hours or 70 hours. Okay, any change any change of more than 14 from the previous baseline is already indicated presence of MINS. Okay, so okay, I come to my last slide. Okay, so this is basically the summary of the article produced by American anesthesiologists. So it specifically mentioned about the topic today, the anesthesiologist's roles is always the best coordinator to prevent MINS, to prevent AKI. Okay, whatever measures that Dr. Zaina mentioned just now to prevent, it's actually at the same time preventing myocardial injury. Okay, so it starts with the preoperative care planning, shared decision-making process, informed risk, okay, mitigating risk, planning your intraoperative measures, monitoring the hemodynamic closely, and then post-operative to continue help with the screening, and then give a plan to how to detect and diagnose, okay, and then possibly coordinate the next management. So if MINS is suspected, so it is important to continue aspirin and statin, and the role of the anticoagulants such as the dabigatran. There was a study called MANAGE trial. It shows that patient who is detected for MINS, who's been started on the dabigatran for 2 years, could actually reduce 20% of the further myocardial infarction and ischemia. Okay, but otherwise, overall, it's about all individual assessment, risk assessment, stratification, and planning. So who will be the best to coordinate all of this? It's not, it's anesthesiologists could be possibly the best role to coordinate all of this, because we see patient pre-op, we handle patient intra-op, although it's our nature that we don't normally follow up patients post-operative, but it could be coordinated way earlier. Okay. Okay, with that, thank you very much.
Okay, thank you, Dr. Fazwani, for such an informative sharing session. Now, I would like to invite you to have your seat at the stage, and also together with our first speaker, Dr. Zaina, just now. Okay. Now, I open up to the floor for the Q&A session. You can go to the mic at each of the aisle, introduce yourself and your institution before throwing the question to both of them. Okay, let us start now.
Thank you.
Okay, any question?
Thank you for those wonderful talks. Just one question. I was wondering, do you have a preferential vasopressor or inotrope for blood pressure support, for renal protection, or preventing AKI intraoperatively and postoperatively?
Okay, I think I'm going to rephrase your questions to Dr. Zaina. Is there any preference, vasopressor or inotrope in preventing renal injury?
Is that the question? Oh, okay. Thanks for the question. You mean preventing AKI? Oh, okay. So I think there is no role to start vasopressor just to prevent AKI. In fact, in Rose heart failure, it's been shown that adding dopamine in heart failure patient does not prevent AKI. In fact, it causes more harm, right? So, so the vasopressor indication is basically indicated for the situation of the patient in maintaining the cardiac output. So basically, and when you get the cardiac output, you probably can prevent AKI, but it is not being used just to prevent AKI. Yep. Does that answer the question? I think in fact in KDIGO 2012 and recent KDIGO 2026, if you're talking about dopamine, no, there is no role to prevent AKI, and it is actually a 1A category.
Oh, I just meant what to treat intraoperative hypotension with, which is a preferential drug to maintain blood pressure intraoperatively.
So basically, there's actually a study to compare whether boluses of short-acting vasopressors like ephedrine or phenylephrine comparing to low dose, preemptive low dose of IV noradrenaline as low as less than 2 milligram in 50 mL, the dilution given into the peripheral lines at the start of the induction, especially like we want to prevent for the post-induction hypertension. So there is actually no difference in the outcomes, but it doesn't mean that if it's no difference that it's something practical, but it's still actually clinically very relevant to prevent hypotension. But again, like if you are targeting, if you are starting all of this like low dose NOAD preemptively just to maintain maybe a BP of MAP of 70, that will come in other risks. For example, the AKI. So it has to be balanced anyway. So basically to say that routine vasopressors, even low dose of noradrenaline, may be not recommended.
Okay, is there any more question? If no, I myself got 2 questions to ask to Dr. Zaina. First, is there any role of isotonic or bicarbonate for contrast-associated kidney injury? That is the first question. The second question, if the government have money, what would be a ideal biomarker to predict perioperative kidney injury?
For the first question, no. I think that has been proven in the recent RCT. In fact, we are one of the center in Malaysia in Hospital Serdang. So to minimize risk of contrast associated AKI, the role is still to hydrate the patient with not, you were saying isotonic bicarb, right? Not isotonic bicarb, but probably isotonic solution, right? 12 hours before the procedure and to be followed about 12 hours after. The second question is
Biomarker that would you invest?
Oh, I would invest. So if I have been given the decision, there's a lot of things that I want to invest. But yes, if I think NephroCheck is the team IGFBP biomarker, team 2 IGFBP. So it is a stress marker. It detects a stress to the tubules. So it is not available at the moment. But if there is a role, I think NephroCheck has a role in managing. Other biomarkers, you're talking about AKI in general setting. It may not change how you manage patients. So you get the biomarker. So what? You are still going to manage accordingly. So you don't need to diagnose it earlier because we are still going to do the bundle. But in the evidence for BPAC, Prevaki, I think they're probably a promising role to guide on which kind of patient that may benefit extra precaution. We can plan the ICU stay. So maybe NephroCheck. But of course, in terms of CKD, GN, we have other list of biomarkers that we want that can predict lupus nephritis activity even without biopsy. So there's a lot of different category. Yeah.
Maybe if I would like to add about the biomarkers, about practicality, cost effectiveness. So specifically, if we are talking about the cardiac biomarkers, the only thing that maybe we can apply pre-operatively to predict our patients is we can choose which patients to utilize the other resources like the advanced cardiac output monitoring better. Okay, because there's no way that we can use cardiac output monitoring in all patients. Everyone comes in the high cardiac risk these days. Okay, they all comes elderly, diseases, diabetes, hypertension, but with the limited resources especially from the KKM, so maybe biomarkers would help to identify which patient needs advanced cardiac output monitoring perioperatively or the ICU.
Now, next question to Dr. Fazwani. I think you may face this difficulty, especially on advising our colleague not to do routine echo for every cardiac patient. So how would you advise for those patients who require biomarkers in which proBNP and troponin is more superior than echo?
Sorry, to the doctors or to the...
To the doctors, to the
Yes.
junior one, yeah, the junior ones also.
Yeah, as I mentioned just now, resting routine echocardiography won't actually change much of the management. It's just give us some security. You know, the ejection fraction somehow anesthetists like to know whether above 50% or below 50%. Below 50%, maybe we can cancel the case if that's the thought. But that's not the case. Echocardiography is very it needs to be run by somebody. It's a test that needs to be sent to somewhere. So it requires a place very difficult to get because of the many other patients may be required echocardiography, not only the preoperative. So but however, we have to balance as well what the institution can offer. Many institutions may not have high sensitive cardiac troponin because in the preoperative setting, if we order cardiac troponin, it may not give us also the the true indication because it only detects the myocardial injury at the higher level. So ideally for preoperative setting, it should be the high sensitivity cardiac troponin. So in practical, it still depends on how this institution can accommodate to this preoperative testings. Yeah.
Okay. Is there any more question? Anyone would like to throw a question to the examiners, to the speakers? Okay, if no further question, I think it's best for us to conclude our session today. On behalf of organizing committee, I would like to thank both Dr. Nurul Zaina and also Dr. Fazwani for sharing their expertise and insightful insight today. I hope all the participants, you go back to your hospital, really can apply both the strategies that has been laid out by both of the speakers. The session will have their rest starting from now till 10:15. Then the session gonna resume to subsequent symposium. Thank you everyone. Please enjoy your breakfast. Now can us give a big applause to our both speakers?
Thank you very much, Dr. Diana. That was a very insightful symposium for perioperative care. Okay, now we'll be having a short break for simple breakfast and booth visits.
Few reminders. Don't forget to complete your booth visit vouchers because we'll be closing the entry at 12 p.m. So you take this opportunity to go and complete your lucky draw stamp, okay? And also, yeah.
And for those who still haven't scanned the MMA app for CPD points, please do so with any of the secretariats. You all will be having 12 CPD points for this 1.5 day conference.
We will resume back at 10:30 a.m. Please do visit the booths and you can have your coffee break during the next symposium as well. Thank you.
Thank you.
No.
innovation begins with a trusted partner. Welcome to Star Medic Group. At Star Medic Group, we are committed to advancing healthcare through innovation, quality, and trusted partnerships.
Hear the thunder, bring the rage. There's a rumble in the cage. Feel the trouble, hit the game. It's the final countdown.
Welcome to Intermedics.
Kumpul sertem dari setiap penaja. Dapatkan term daripada Star Medic, Mycomedic dan lain-lain. Setiap sertem membawa anda lebih dekat dengan cabutan bertuah. Jangan lepaskan peluang ini. Dapatkan sertem anda sekarang.
Hello, Mind Ray.
There's a rumble in the cage. Feel the trouble, hit the game. It's the final countdown. Oh.
Testing. I think we'll let the crowd come in, trickle in slowly. We better get a move on so that we can finish on time later in the afternoon. Okay, Assalamualaikum and very good morning to all the participants. Actually, today rasa macam cakap dengan kawan-kawan. So I think most of the the hall is someone that I know or know me or I know of them. So it's very pleasant. So welcome to the 6th Symposium on Medicolegal. Just a brief introduction. Anesthesiology is a specialty where every decision, wow, we're cheering, yeah, NS, where every decision carries significant responsibility. So while our primary focus is delivering safe and high quality patient care, we must also understand the legal and ethical framework that governs our practice. So today's symposium, we'll be examining, I'll use a law term there, examining the medical legal issues, okay, from two complementary perspectives. Okay, first from Ms. Charlene on how anesthetic practice is scrutinized in the courtroom, and the second one from our none other Dr. Guna, how effective informed consent can reduce medical legal risk while strengthening our patient care center. Patient-centered care. All right, so let me introduce the first speaker. It is my pleasure to introduce Ms. Charlene Andrian Chin. You siap dengan ada music background to introduce you. So Ms. Charlene is a partner in the dispute resolution practice group at Mercer's Raja Darrell and Low, specializing in civil and commercial litigation with a significant focus on medical legal and dental legal practice. She regularly represents healthcare professionals, thank you, in medical negligence claims and disciplinary proceedings and has appeared at every level of the Malaysian courts. She was also part of the legal team involved in landmark federal court medical negligence appeals that clarified important legal principles concerning a doctor's duty of care and the duty to advise patients of material risks. She has delivered more than 80 lectures, nationally and internationally on medical legal issues. Today she will speak on anesthesia on trial, when the courtroom lights rise. Please join me in welcoming Ms. Charlene Andrian Chin.
Quality and trusted partnerships.
Thank you very much, Dato, for the kind introduction. Very good morning, salam sejahtera. An absolute pleasure to be here. Now, usually when I'm speaking in court, I don't have any music that I have to compete with. And to make things worse, I am perhaps the only lawyer in a room. Okay, it's okay. All right. Thank you very much. Now, I usually don't like to tell people that I'm a lawyer, especially when I go and see a doctor. And when they say, okay, where do you work? I usually just say I work in KL. And my husband gets so irritated because you never answer the question. Because when they know that the patient is a lawyer, they start treating you very differently. And in that list of advice of options, one of the options they will also always include is, you may also go and see a different doctor. Right? All right, ladies and gentlemen, today I will be speaking about, this is the topic, anesthesia and trial, when the courtroom lights rise. So I'm just going to go through, we're going to go through one case study and I'm going to pick out some of the litigation issues that are quite specific, I think, to anesthetists, but also to the medical profession in general, all right? Now, before we visit the courtroom, I first want to bring you to a different room, a room that perhaps you are more familiar with. I would like to transport you back to your OT, wherever it may be. Now imagine this, an elective case, routine induction, suddenly there is unexpected hypoxia. Patient requires ICU admission. 6 years later, you are then queried incessantly and quite aggressively about your documentation during the 5-minute period of induction. My first question to you, ladies and gentlemen, at what point did this become a medical legal case? Anyone? At what point do you think it became a medical legal case? The patient here is not a lawyer, by the way, because if he's a lawyer, you say the minute the patient walked into your room, that was a medical legal case. No. At what point do we think it became a medical legal case? Anyone? Dr. Guna? The pre-op assessment. Pre-op assessment, interesting. Okay. Now, is every adverse outcome actually equivalent to negligence? How many of us say yes? Nobody. How many of us say no? No, this is interesting. Let's explore this during the Q&A. I want to know why no. Okay, that's very interesting. I'm not saying the answer is yes. I just want to know why no. Okay. Now, imagine this. What can you remember of a routine case 6 years ago? Anyone can tell me a routine case? Very little? Routine case, right? Now, if I had to pick a patient's file from 6 years ago of a routine case, would your notes be able to tell your full story? Why y'all smiling? Some laughing. Okay, I know the answer. I won't press you any further. All right. Now, let's talk a little bit about the messaging for today. I am not here to, to scare anyone. That's the last thing I want to do. I defend doctors from the start of my career until today. My entire career, my legal career has been dedicated to actually defending doctors, both in public and in private. So sweet. No one else will clap their hands in a different room. But no, I think the message also is that these messages are coming from someone who, likewise, you have dedicated your entire profession to saving people. There are also some of us who have dedicated hours to actually, protecting the medical profession. Now, the message actually is, when it comes to medical legal, it can happen to anyone. We always read the news. Who read? Dr. Guna was just telling me about the recent case in Shah Alam. Almost every week, you get a WhatsApp link of a medical legal decision, correct? Now, out of those links that you get, how many do you see of the doctors winning? Macam tak wujud. Betul tak? Patient menang je, kita dapat news. Correct? That's the news that we seem to be getting. Okay? And sometimes when we read the facts, it's almost as though it's unbelievable and we think, no, it can't ever happen to me. But just bear in mind also, what you read in the press is obviously summarized, condensed, and usually done by a reporter, not necessarily a lawyer. So the views are quite different. Okay? But the message is actually this. Litigation doesn't start in the courtroom. It starts way before that. Dr. Guna's answer is actually really good. The pre-op assessment. And very few will probably answer that. Okay? And there are a lot of factors that take into account your communication, your documentation, the system that you are in, and also the clinical judgments that you make. Quite apart from the system, all the other three factors are purely and entirely within your prerogative. That is the good news, ladies and gentlemen, if there's any good news that I bring today. Okay? Now, let's just very quickly, why do anesthetists actually end up in court? First is also the nature of the specialty, and I don't need to go through this. This is something very, very common to all of you. Now, what are the common allegations that we see against anesthetists in court? Airway mismanagement. We had a very big case at one point recently. Okay, delayed recognition of deterioration, inadequate monitoring, drug errors, regional anesthesia complications, failure to advise of risks and options, and consent. I'm not dealing with consent because Dr. Guna will actually deal with it. Okay. Now, this is a very brief process of the journey from when something goes wrong to court. And the reason why I wanted to highlight this is for you to understand the journey. Sometimes we think you get sued and you should go to court immediately. And the doctors get very frustrated because it takes years and years. And sometimes those years can be very, very stressful. So you start here. Usually it's a complaint or a request for a medical report. How many of you, okay, anyone here in private practice? Private, there's some. Okay, those in private practice, when you are asked for a medical report, do you just straight away issue it on your own? I think many do. with the consultation of the notes as well? Yes. Okay. Some doctors actually approach lawyers, right? And sometimes I can understand why it can be frustrating for them because the lawyers take a bit longer than what a doctor would. But the added advantage is that the minute I read a complaint, I usually can roughly tell if this is a disgruntled patient who is just upset with an adverse outcome, or are they serious about the allegations? The tone is quite different. Each of you doctors may have 1 or 2 complaints in your career, 3, 4. Sometimes nowadays it's getting a bit more. But imagine us sitting in our office and reading complaints every day and watching which of those actually go on to become cases. So after a while, you almost are aware. I can even tell if a letter is written by a lawyer, or sometimes it's ChatGPT, right? Because we see the initial WhatsApp with the patient and the doctor, and then we see the letter of complaint, and we're like, oh my gosh, it's totally different. And all those factors actually affects or should be taken into account when you are responding. The claim does not start when they file the claim. It starts when there is an expression of dissatisfaction. Usually it's earlier. Now, the second thing, sometimes you get a letter of demand, sometimes you don't. Usually you do. I have had a doctor who put the letter of demand in, he didn't even open the envelope, so he didn't know it was a letter of demand in his defense. A year and a half later, he was served with a judgment in default. He then calls me up and he says, Charlene, I received this document, it's a summon. I said, okay, can you give me the writ and the statement of claim? No, there's no writ. I said, then what is the title on that document? Penghakiman Ingkar. I said, that's a judgment in default. That means you didn't attend to the suit. No, I was never served. So of course, we went and did a file search and they exhibited everything in the affidavit, how they registered post. It was his nurse who signed the documents. The time had lapsed. He didn't even open the envelope. There was a judgment in his name. We had to undo that. Okay. Then after letter of demand, they file a claim and they serve it on you. Now, hospitals, both government and private, a lot of you like to accept this service on behalf of the doctors. And if you do, please immediately give it to the doctor because time can start running. And I say can because if you're a very particular lawyer, sometimes you will argue it's not been served properly. And until and unless it is served properly, time cannot start. Okay? And then you file pleadings. Extremely important. We get a lot of complaints from doctors when we're filing their defense, when you're drafting the defense. Charlene, why do I have to meet you so many times? Okay, doctor, we'll meet on Zoom. Okay? You know, I'm very busy. I only have lunchtime. Can I give you half an hour? I mean, I'm okay with that, but I think you need more time. Your pleadings are so important because they actually define the scope of the claim and the scope of your defense. I'm going to go through a case study later and I'm going to deal with this point. And I'm going to show you how important your defense is. If your lawyers or your AG's chambers lawyers are calling you for a meeting to discuss your defense, please give them the time that they want. And if you do not get a call when you are preparing your defense, please make that call to your lawyers. I would be very surprised if a defense can go out without any input from a doctor. Zero defense have left my desk without an input from doctor. It is impossible, even if we think we know the medical issues. Never. Then you prepare for trial. And actually, this is where the bulk of the work happens, but it happens on the lawyer's side. We are preparing your case summary, we're preparing your list of witnesses, we're trying to get experts, and we'll talk about experts later. Okay? We're preparing your witness statements. We're doing all the heavy lifting. And then after that, we go to trial. This is the most stressful and crucial part. But if you are well prepared, I've actually seen doctors who are actually quite excited because they want to vindicate themselves in the stand. I've actually seen some of them. And those who are well prepared, of course. Okay? And then testimony generally divided into 3. You get examination in chief, which is now your witness statement. And then the second part actually is the juiciest part, which we always see in suits, in all those law series. They will always jump straight to cross-examination. Okay? And then finally, there is re-examination. And then you've got submissions by the lawyer's decision. Between this decision and the claim, it can be between 3 years or so. If it's in the lower courts, it can be faster. And if you're not happy, of course, there is avenue to appeal. So this is just roughly the sequence, okay? Ladies and gentlemen, this is actually the KL court, because this is Wilayah and KL, right? So this is KL, this is the court, the High Court in Shah Alam. And this is actually what this is the High Court in KL looks like. This is not a full picture, but let me try and tell you. So you see this seat here is where the judge sits. And this door is where the judge comes in from. So it's like the judge is on an elevated place, the door, and behind that door is their chamber, like their room, their office. Okay? And then, okay, after COVID, we had all these plastic things, but before that, we didn't. So you see these people sitting here? Now, this is where the Juru Bahasa and the court secretary and all sits. Okay, and then this table is what you call the bar, not where you drink, but where we practice. So the bar, that's why lawyers we are called to the bar. So once you are called to the bar, you can sit there. Those who are not called to the bar can't. And then behind these seats, you see here, this is actually the defendants, only for criminal cases, the orang kena tuduh, OKT, will sit there. And then behind here, behind this area, there will just be chairs for public to sit. Okay? Now, what do the courts look at when we are assessing a medical claim? I'm not going to go through this into so much detail, but actually they will just look at the ingredients of negligence. So negligence, you know, you've got 4 things. Duty of care. Is it disputed that you owe your patients duty of care? No, right? 2 crucial things. Breach and causation. Breach is if you had breached that standard. Or another way of looking at it, did you fall below the standard? Then the third ingredient would be causation. Causation is very legalistic. It is, sometimes lawyers don't understand it, and with the greatest of respect, sometimes the courts are clarifying actually what really is the law on causation. And I'm going to also deal with this point in our case studies. Only one case study, but it actually touches on all these points. And then damage. Okay? Now we'll actually go and look at the case study. I'm going to bring you through the facts of this case. Okay? Day 1, admitted for labor pains at 6 o'clock in the morning. Then just before 1, the patient delivered a baby girl. Okay? An hour later, there was bleeding from the episiotomy site and vaginal wall tears. She was sutured. A blood test was ordered and blood transfusion also ordered. Still on day 1, 5 in the evening, she suddenly became unresponsive. Thankfully, the ONG was actually there at the time. So as he was speaking to her, she then just closed her eyes and became unresponsive, and he immediately attended to her. Okay, he called in the anesthetist. You see a CVL line inserted, and blood transfusion was started. Now, this is the first collapse. Blood test showed DIC. Now we go to day 2, 9 o'clock in the morning. The DIC was actually corrected, and her coagulation profile was normal. We see a slight improvement. And then we go to day 3. She was actually transferred from the ICU to an ordinary ward. 45 minutes after that, second episode of cardiopulmonary collapse, okay? And she was managed accordingly. This is what we're going to call the second collapse. At that point, after 3 days in a private hospital, the family then requested for a transfer to the general hospital. The following day, 4 a.m., 4 a.m. This is very early. So the doctors did act very fast. She was actually transferred to the general hospital. Day 5, day 6, day 7, day 8, and day 9. Anybody wants to guess why my chart is blank? Anyone? It's supposed to be an interactive session. No notes. No notes maksudnya? No documentation. Any other? Sorry? Oh, so no need to write because it's the same. It wasn't the same. That's really a very interesting answer. So what actually happened was, at the trial, it's not that the GH had no notes. Let me make this clear. The GH had notes. Let me make that clear. But at the trial, the court wasn't furnished with the medical records from GH. Okay tak? Tak okay. Kenapa tak okay? Tak okay because of what happened on day 10. In the evening, unfortunately, it's a very, very sad case. Patient was actually certified brain dead and she subsequently passed away later the same day. What went wrong here? Can anyone guess? Just based on the facts that I've given us so far, what do we think went wrong? Are we even in a position to opine? What do we think went wrong? Anyone's guess, right? Okay, so now let's look at the first issue. It's a legal issue, but it is so important. And the reason why I say important is because this is the one thing that lawyers need the doctor's input on. But I don't think we do enough. This is the plaintiff's pleaded case. Maksudnya, ni yang telah dipleadkan oleh pihak plaintiff dalam pernyataan tuntutan. Okay, in the statement of claim, they actually pleaded postpartum hemorrhage leading to premature death. And this, actually, sorry, I should have made it clearer. This is under the heading of cause of death, PPH. Right? We saw that the patient, I'm not sure if I put it there, but in the medical records in a private hospital, the mother had lost about, immediately after birth, 750 mils. And then after that, about 1 to 1.5 liters. And we know that the definition of PPH is bleeding in excess of 500 mils over a certain period of time, right? And I think WHO in the 2026 guidelines has actually said if there is an excess of 300 mils of bleeding coupled with certain factors, you can also classify that as PPH now, right? So this was the case. This was the case that the anesthetist and the ONG, they sued the ONG, they sued the anesthetist, they sued the private hospital. They didn't sue the government hospital, okay? Now, when you read the statement of claim, that is your roadmap to what the patient is going to present in court. So when you see the cause of death as PPH, who do you think they're going after? ONG, right? They also had particulars of negligence against the NS, and it was the general ones, for example, failure to monitor, failure to the usual ones you see lah. You didn't advise of risk, didn't monitor adequately, and you caused the damage. That's fine, but the cause of death is PPH. Remember the 4 ingredients just now? Duty of care, breach. What is the third one? Causation. I must cause your injury. Then in law, you can say that I'm negligent. Any of those 4 missing, you cannot establish negligence. Okay? What was the court? And I just wanted to make sure because I was reading it again, this went to High Court. And then the Court of Appeal actually affirmed it. The anesthetist was found negligent. The ONG was actually found not negligent. Right? And this is why. The unsuccessful insertion of the CVL on the left side and the broken catheter tip had caused the deceased to suffer a left-sided pneumothorax and air embolism, which materially contributed to the deceased's death. I pause here. What do you think the anesthetist was or thought that the case he had to meet in court? PPH. And suddenly at trial, the plaintiff adduced an expert, she produced an expert opinion, and she then said, actually the patient died of air embolism. Was it pleaded? No, it was not. So from a legal point of view, the question I asked then is, it's basic, it's 101, evidence rules. If it's not pleaded, then you cannot advance that position at trial because the entire reasoning behind a civil trial is that there's never a trial by ambush. It's fair. The plaintiff must be clear what your case is. Kalau nak tukar boleh. It's not that you cannot change. You can change. But if you want to change, you cannot change too late in the day. The defendant doctors must also be given the exact same time and the fair opportunity to also prepare their defense. For years, this anesthetist thought he was going to go to trial for a PPH case. On the stand, the expert now says it is because of air embolism. If I was the defense lawyer, I would jump up and I will object. I will object and say it is not pleaded. And if the court insists, then I will ask for an adjournment to allow me to get expert evidence. Okay? Just because you're an anesthetist, for example, it's not uncommon for you to also get an expert opinion from a different specialty depending on what the claim is. We do that sometimes. So for example, we've had a cardiologist, I'll take an anesthetist case. And NS was sued, we acted for the NS. And it was also tied to some surgical issues. We also got a surgeon to come in as an expert to just cover all bases. Okay? So this is one issue. So the questions I asked is, what was the plaintiff's pleaded case? We've already gone through that. It was PPH. But what did they produce at trial? It was air embolism. Okay? There's a bit of a disconnect there. The second issue I want to raise is medical records. Now, as a doctor, I think this is what is usually sometimes missing. Of course, the lawyers should pick it up. But to be fair, it is the plaintiff's duty to adduce these documents because you are alleging that despite the patient being in the private hospital for the first 3 days, and then a week later she passes away, they plead because of PPH. Then they should actually adduce all the documents. And if you don't adduce the documents, I would argue you have failed to discharge your burden of proof. The burden is always on the person who asserts. Okay, it is always the plaintiff who has to prove. Right? But also as the defense, and I've had cases where I have said, hey, you went to a second hospital. I want the notes from the second hospital. And the doctor has actually told me, but what if the notes make it, reflect badly on me? So be it. Then we know what we need to do. We don't fight it in court. But I need to know the full picture. Right? So as a doctor also, you should be alive to these things. Always help your lawyers. Always help your medical legal unit. Okay? Because there may be things that you see that they don't necessarily see. So the big question I ask is, where were the records from the GH? We are not talking about 1 hour. We're not talking about half a day. We're not even talking about 2 days. We are talking about a week. What was the patient's condition when she left to GH? She was getting better, right? Remember from ICU? She then went to normal ward. Okay, her coagulation profile, all of that was normal. Her BP, her vital signs, everything was stable. They transferred her well. And then she was in the GH for 7 days. I'm not pointing the finger at the GH. I'm not. I'm just saying we have an incomplete picture. And when we have an incomplete picture, then as a lawyer, I ask these questions. Where were the records? How is it that there were so many defendant doctors, their lawyers, the patient's lawyers, the judge? Was this question ever asked? How did the expert, and actually this is a bit more interesting. The plaintiff had an anesthetist expert, one of yours, right? Your fellow colleague. And she actually concluded from the 3 days punya notes that on day 10, punca kematian antara lain termasuk air embolism. But do you notice that her words in her, okay, you may not have noticed, but when I read her report, her words, and she used a very legalistic word, materially contributed to. What does that mean? There is a second cause. Because if it was the only cause of death, she would say the cause of death was air embolism, or the patient died because of air embolism. Her words in her report was, the air embolism materially contributed to the death. Then my question as a lawyer is, what is the other contribution? Tell me. What is the other contribution? Because maybe that other contribution is actually a bigger factor compared to the air embolism. Perhaps. Then I would then look at the notes. Right? So these are things that you really have to scrutinize. Number 3, do we know for certain that there were no intervening acts? How can you tell that for those 7 days, nothing had happened? We don't even have the notes in GH to know that there was another insertion on the left side of the neck. Do we know? We don't. Could the air embolism have happened there? It could. Right? And the question I have for you, do your records tell your story? Okay, this is a safe space. How many of you are quite happy with how you document your records? Can I see a show of hands? Dr. Gunalan, Dato? La. Again, how many of you are quite happy with how you do your records? I want to see more hands. You have to have the confidence. Okay? We come, we give our time, we are here, we want to educate the profession because we want to empower you. It is not to scare you. When you know better, you do better. And when you do better, actually you approach your profession with a renewed sense of confidence. Yeah? Okay? And the third and final thing, let's talk about experts. How many of you here has actually been an expert before? I know, yes? No? No? That's what you should. Expert? Yes? How many of you have been an expert? Expert. How many of you have been approached to be an expert? I won't ask the next question, but said no. Can I plead to each and every one of you, if you are approached to be an expert, please, if you are able to accept that brief. Because people like myself in court, we cannot advance any argument convincingly without the backing of an expert. Our best cases where we have won, it is always with an expert. Okay? We always need, and you have to think about it. It is very daunting. Okay, I clever to say now, okay, please. But if actually, I would never want to be cross-examined. If possible, I never want to be in court because I know exactly how cross-examination works, right? It is very daunting, but it is necessary. It is necessary. Okay? Now, the legal standards are actually this. The Polam test requires you to be judged by your peers. That's why you have experts. The courts are actually trained in law, not in medicine. And Bolitho says that an expert report has to be logical. So I would be the first to question that expert report in that previous case to say, how is this logical without the notes? There is no way you can come to a conclusion. You may still come to the same conclusion with the notes, but have a look at the notes. That's the point. Okay? And a lot of doctors always think that the law requires you to be perfect. They don't. We don't. The standard is a reasonable standard, and it is actually the minimum standard that you need. And so, I also ask the question, do experts do the same? I feel not. When I'm here at the Medicolegal conference, when I'm speaking, we all agree, the doctors are under attack, the standards are too high, there's no room for error. And then when I read the expert reports, even the experts, they're very critical. And I'm not saying don't be critical. You have to be critical where necessary or where appropriate. But the standard is not the perfect standard. So I've seen actually expert reports. I would have done A, B, C, D, E, F, G, like a list of maybe 12 or 13 items in an emergency. You really think you're going to go through a list of 1, 2, 3 in emergency? You're just going to do what is necessary at the time. Correct? You're not even and there was once where an expert actually said, I would have documented in a shorter period of time than the defendant doctor. I was thinking, you, Anes, you attend to the code blue, and then what do? You just pass the patient on to someone else and you go and do your notes? Of course it's okay. It's your own colleague. Your colleague should be commended for journeying with the patient, making sure the patient was okay, and then coming back to do your notes. And that's okay. All right? So sometimes as experts, we also feel that when they are on that desk with a pen or typing, for some reason, because you feel you're an expert, the levels then suddenly rise. Because you might feel that's the standard that's reflected on you. But don't be afraid, because the message I have for you today is that the law of the land is that the standard is one of reasonableness. If you choose a higher standard, you are just imposing that on your own accord. Don't do that. Stick to what the law is. Okay? Do not make it harder for you, because times are already quite difficult. Okay? And what happens when they disagree? A lot of people always say, Allah matilah, plaintiff ada expert report, defendant ada expert report. If you have a good defense lawyer, diverging expert reports is not something they fear. Because the law actually says that the only way actually a plaintiff can win is if the defendant's expert is not logical. The courts for some reason think that they have to choose between plaintiff and defendant. Tapi sebenarnya tak. And I think this is unfortunately an issue where lawyers are not brave enough to advance that argument in court, because it is a very difficult argument, especially when you have the patient in a wheelchair sitting right in front of you and the entire family members looking at you. And when you walk into the court, they will actually tell, I've actually had an experience when I walked into a court, but with Dr. Daryl at the time, I was his second chair, and it was an ONG matter. And the mother, unfortunately, actually very similar to this case, also died of PPH, but we argued that she died of AFE, amniotic fluid embolism. And as we walked into the court, the husband saw us and he told his 2 daughters, these are the bad guys. Oh, terasa. Right? Even as a mom, I feel that. I mean, every case is difficult, you know, and we are there to defend the process actually. Yeah. So just bear this in mind. And then when we ask questions about experts, use simple language. It is very impressive. Everybody knows that doctors are intelligent. Nobody in society doubts that. Okay? So when you write your expert report, plain, simple language, because you know why? That's how you get to the judge. And whether you like it or not, it's the judge who decides. The judge gets you, you're set free. Okay? And then remain independent and impartial, please. It is very important to remain independent and impartial. So don't be overly supportive, but at the same time, don't find things just against the doctor so that I am impartial. That's not what impartiality means. Impartiality means regardless of the name of this person on the entitlement of the court suit, my view will be the same. Doesn't matter who, whether this person is my friend or not. Okay? And then recognize the limits of your expertise. Yes, that's all I say. If you're an anesthetist, please don't opine on ONG matters, don't opine on surgical matters, okay? Just stick to your lane. Distinguish facts from assumptions, very important, okay? Always support your opinion with clear reasoning and literature. And I know this is why the practitioners always like, oh, no, please ask an academician. And then we go to the academician, then we find that they're actually really good. But actually what we actually need is both, right? We need the practical side and we also need the academic. So we have to find that balance somewhere. And remember, whenever you are appointed an expert, your overriding duty is to the court. It is actually stated in the rules of court. And that is what you would actually affirm your oath to. Okay? And then, ladies and gentlemen, I just want some takeaway points. Remember, the courts do not expect perfection. Okay? What we actually expect, or what the courts expect, is a reasonable clinical judgment, of course. Right? That's your main thing. Appropriate communication, good documentation, and practice that is consistent with accepted professional practice or professional standards. All right? And I just want to probably end by this. Actually, the strongest defense is not so much written by the lawyers after the event. But I must also say that your lawyers are also very important, of course, right? But your strongest defense actually, quite frankly, lies in your hands. And they start from very, very early on. So do not think about medical legal issues as something I need to be worried about. No. It is actually can be controlled with good habits. And if you have good habits with every patient that walks through your door, even if the suit comes, and I hope not, oh God forbid it does, okay, but even if it comes, you can be rest assured that your good habits will come to your aid. Okay? So with that, ladies and gentlemen, thank you so much. I'll now hand over the time back to Dato for the next speaker.
Thank you, Charlene. Very insightful presentation. Although you tried to engage some of us, answer some of us not, but I think, yes, it's very good. Okay, but you've shown us what can happen and when can happen, and you know, we'll do Q&A at the end, okay, guys? I'm sure you have lots of questions for her. I would like to introduce our second speaker. It's my pleasure to introduce Abang Guna. He's actually my registrar since way back. Okay, Dr. Gunalan graduated from University of Malaya and obtained his Masters of Medicine from UKM. And then he later completed a Master of Laws in Healthcare and Medical Law from Taylor's, giving him the unique perspective of both an experienced and someone formerly trained in healthcare law. With over 25 years under his belt with being a clinical, with his clinical experience, including more than 15 years as consultant anesthesiologist, he has also prepared numerous expert witnesses, as he had put up his hand, which I put up. Yoo-hoo. Okay, thank you for that, Guna. And he has appeared before High Court, yes? Ooh. As an expert witness and in medical legal cases. So today he will present on consent in anesthesia, how much to explain. Close yours.
Thank you, Wan. Thank you, the organizing committee, Mr. Dr. K, as well, for having me to come and speak for this topic. It's always a bit difficult to speak after a very pretty girl standing in the corner there, and then now you're stuck with an old man, haggard. I had a long weekend as well somewhere. I just came back. Okay. All right. Charlene spoke a bit about expert witness, the process and whatnot, which is very interesting. But I think this is a very difficult topic, and it's a difficult topic because not possible to cover in 30 minutes, but I'll try my best because consent is actually one of the toughest part of our anesthetic day-to-day work that we do. I think we all are very clear in terms of, when you go to UKM and UM and USM and we graduate, they talk a lot about anesthesia, induction, maintenance, this drug, that drugs or whatever. But how many of our lectures actually spend time on the process of consent taking? I don't know. I don't remember us talking about it. And Professor Zaidi always scolds us, what is his word I use? Mangkuk ayun, yes, that one we get a lot. The mangkuk ayun part I cannot forget. But consent, when we talk about consent, how much of the things that we do in the workplace? All right, so if you talk about the definition, let's start with the definition first. Now, if you look at our own local guideline, the Malaysian Medical Council has got a definition in terms of consent. So what exactly is consent? It's something which is voluntary. It's an informed agreement. It is agreement between you and the party that is either undergoing a procedure or the party or the next of kin who's actually going to consent on behalf of the patient who's going to go for the procedure. Now, it requires sufficient mental capacity. That means you can't take a consent from somebody who's drugged, overdosed, insane, mentally incapacitated, a child who's less than 18, geriatric adult who is unsure what the procedure is all like. So it has to be, that has to be taken into account. You can't just, it's not just a form that you just shove in the face and ask them to give a signature, no? Right. This part is actually the most important part. However, many of us slack. Why I say it's slack? Because most of the time, we just give the form and say, uncle, sign, ini kita akan buat, ini kita buat, that's it. The poor uncle on the other end will say, okay, doctor, saya buat apa aja lah, and then sign and go on, But nothing happens, no problem. Something happens, that is where the process starts. So they will say, I didn't understand what the doctor said, I didn't know what he was telling me, I was unsure what the process. So this is actually where a lot of times the gap happens, right? So it is an ongoing process. It needs good, clean communication. Both parties have to understand, and there has to be a mutual respect within the patient and us. And remember, it must not be coerced or forced onto the patient. The patient must be given the option to decide on what he or she wants to perform on a. Now, it is mandatory. No way you can do any procedure on a patient without getting the patient's consent. So that's number one. So if you don't get the consent, what happens? Of course, we all know lah, MMC will pull you up. Of course, in the litigation, the courts will also look at that. That's number one. Now, in an emergency situation, there is a little bit of an exception. You can't get a consent from somebody who's collapsed on you in the A&E or in the recovery room. Okay, there's no such thing. In that kind of situation, duty is to do what is necessary for the resuscitation, and then you think about consent or whatever later. Like say, for example, if you have time, you've intubated the patient, you need to do a central line or you need to start the patient on dialysis, then the consent process can actually be done with family members or whatever, right? But you are allowed certain exceptions when it's an emergency situation. All right? Okay, this part again is where a lot of times we have a lot of challenge. How much do we need to tell the patient? How much would the patient know? How much would the patient understand? How much would the patient understand about the options available for you? And how much alternatives that you have to give to the patient? Now, this is a very tricky problem, especially in our countries. I'll explain to you in detail as well. Not only that, you must also look at the patient and decide what is the risk that may be materially relevant to the patient as well. That means if I'm seeing Siti Nohaliza for thyroid surgery, I jolly well better be sure that I tell her about the risk of losing her voice. All right, that is a material risk to her. If I'm having a badminton player coming to me for a tendon repair, I better make sure that he knows that loss of function or loss of numbness or weakness is something that is materially relevant to him and has to be disclosed as well. So you need to actually tailor your consent taking process to what is the patient coming to you as well. All right, and he has to be in a very clear, communicated in a language that he understands, and in the emotional state and whatnot. Right. I told you about the medical emergency and also the minors. Now, in Malaysia, very rare, but occasionally, sometimes we may bypass the consent from the parents or the consent from the next of kin, especially if the treatment overrides the decision of the family member. Very rare, but I can tell you of a case of a patient who had a need for blood transfusion. There was a Jehovah's Witness. I mean, you have heard of Jehovah's Witness, where they refused blood transfusion. So a court order was actually given to the university hospital to actually allow such treatment to be made. But this has to be done with a court order. You can't force transfusion on somebody who doesn't want it. Now, let's go to the practical part of it in this country. Now, we are not all English speaking lah. That's number one. All right. So you may be an anesthetist. I did my work in Sabah as a houseman and medical officer. I was in Sempurna, and there the Bajau Laut, right? So they have a completely different way of talking in Malay. They have a Bajau slang kind of thing, So gastric is dugal and all those kind of things. So how do we actually tell them that these are the things that you're going to do? It's very, very difficult. Sometimes you may have to have a relative of them to actually come on board. In this part of the world, you have so many like Chinese, not only Chinese, they have Hokkien, Mandarin, Cantonese and whatnot. So it is a very complicated process. Not as simple as what it is in the West, where it's all, first language is all English. So usually it's quite straightforward in that sense. Now, is it possible to cover every single risk out there? Hands up if you can actually do that. No way. All right. Basically is this, nearly impossible. But what you can do is to cover at least the basics. If you're going to intubate somebody, make sure you tell them the risk of hoarseness, the risk of airway trauma, the risk of difficult intubation. At least those things are covered. No? The very rare things like you put in a central line and you die of venous air embolism, no way the anesthetist is going to tell that. All right. And how is he even going to be predicting that? That case is a very sad case. All right. We spent a good one whole day sitting in the College of Anesthetists, Academy of Medicine, went through the case in detail, including the expert witness. It was quite a good fiction, I would say. Very nice novel written in fiction manner in terms of articulating what could have happened. Unfortunately, the court bought that story, so it was very unfortunate for all of us. All right. I personally find that the most difficult part of a consent is not about consent with the high-risk patient. The high-risk patient, I do a lot of cardiac and neuro in my center. When I go to my patients, the expectation from the patient as well as the family is they are highly likely to die from this surgery. I mean, that's reality. They will say, doctor, am I going to survive this surgery? Usually when I talk to them, they say, look, I'll talk about risk of stroke, risk of heart attack, risk of renal failure, risk of blood transfusion, DIVC, or whatnot. They usually tend to accept that. And that process usually is well documented. We sit and spend time, make sure they understand that. The problem is not those high-risk cases. The problem is the ASA1 with a simple, straightforward surgery that is actually ending up with a complication. I'll give you an example. You probably have a patient coming in for tonsillectomy. You would have probably told the patient, look, everything will be okay, your ASA1 should be no problem, whatever. Later in the recovery, the patient bleeds, gets into hypoxic and whatnot. So now the whole problem starts. The consent actually didn't explain about the risk of HIE and all those things. Other gallbladder surgery, for example, we do it so often. Sometimes the patient end up with sepsis, all right? Sometimes the patient may end up with an MI because of intra-cardiac issues as well. So there are many, many things that we can potentially not even be able to cover. That is the actual problem. The relatives are generally quite okay if they're actually knowing that the patients are actually quite high risk in the beginning. Now, the other thing is also with your obstetric patients. Most of the time, we never actually tell the obstetric patients that you're going to be dying of amniotic fluid embolism. Have we? No. You're going to be dying of postpartum hemorrhage. Those are all very, very minor risks or major issues in complication, but they are kind of like the very rare complications that can happen. All right. But when it happens, again, the family members will blame us. How come you did not let this risk of this thing happening? You know. Now, there are other issues also basically when you have different family dynamics. When you're taking a consent from mother, taking consent for the mother who's going to go for a hip replacement who's geriatric, then you have two different sets of siblings who have two different wishes. One says go for the surgery, one says don't go for the surgery and whatnot. So these are all the family dynamics that we have to deal with as well. I'm going to talk a little bit about you in the Ministry of Health. Now, the reality in the Ministry of Health, have you ever been able to spend more than 15 minutes for a consent? A bit unlikely lah. At best, 5 minutes. At best lah. Okay, 5 minutes. But in 5 minutes, do you think you can actually have the entire discussion of lecture on consent done? No way as well. All right. And the reality on the ground is something that the courts may not actually appreciate. I'm sorry to say, but sometimes we are rushing through it. Sometimes we have 10 patients waiting for us outside the NS clinic. We have only 5 minutes per patient. We tell all the salient points, but sometimes we may miss out. These are all the realities that we face on the ground. Okay. Some patients have a selective hearing lah. The selective hearing is this: doctor, I just don't want to know everything. Just do what you need to do. When they say that, you assume that the patient understands and assume that the patient wants you to do that. But sometimes it's not the case. When things go wrong, they turn around and say that, look, you didn't tell me exactly what I meant, what I needed to know. Some surgeons, in fact, in private practice, a lot of surgeons get upset when we do this. So as anesthetists, sometimes we tend to overstate the risk and complications compared to the surgeon. Surgeon wants to operate on the patient, okay? So he's planned the surgery nicely. In 2 weeks' time, the guy is coming for total knee replacement. I see the patient the night before, and I tell, uncle, risk of DVT, risk of pulmonary embolism, risk of cardiac attack, risk of this, risk of that, risk of that. Uncle will say, ayo, nobody told me this. I don't want to go for surgery. In fact, there has a lot of times, many of my surgeons, my surgeons in my hospital are quite okay lah, but a lot of surgeons have got issues with the anesthetist when they do this. All right, and what happens is the anesthetist becomes a not so popular anesthetist. He then switches to an anesthetist who's willing to do the high risk cases or willing to cut corners. So that is a danger of private practice lah. In my center, I have a surgeon who's married to an anesthetist. So that surgeon is quite comforting with me in the sense that, look, Guna, you tell what you need to tell. If the patient doesn't want to do, it is good for us. You know why? That is the patient who's likely to be a troublemaker if something were to go wrong. So it is money that we lose, never mind, but we do our part. Okay. So we have lost patients, lost in the sense of not on the table, lost patients to surgery because they just say, I want to get a second opinion. It's okay, fine with us as well. If you want to go for second opinion, well within your right. Okay. Now, children come in for circumcision. There are many, right? All right. How many of us actually tell about the risk of dying from circumcision? No, right? But there's laryngospasm, there's bronchospasm. You know, how many of us, if you've done enough kids, I can bet you that you had one laryngospasm in your life. Ada ke tak? Ada. You know, scary, right? All right. And you know that you're minutes away, seconds away from losing the child, right? Would you have actually explained that to the family prior to that your child might have laryngospasm and whatnot? No way. No parent will actually say, this is a risk that I'm going to take, my child might die from this surgery. No way. So again, the reality is the consent taking is actually a very difficult process. we will not be able to cover most of it. This one is the latest trend lah. A doctor from Singapore, doctor from KL, doctor from California syndrome is something that is a very unique thing. Not, I won't say unique lah. In KL, sometimes you may not see anybody, no family members, and all of a sudden something goes wrong. All of a sudden, suddenly somebody appear. I'm from Singapore. I didn't see my mom and all the things. How come you didn't do this? How come you didn't that? And then suddenly the whole thing becomes the daughter who's actually signed is not the daughter who's actually the decision maker of the family and whatnot. So these are all things that can potentially happen on the ground as well. We see a lot of this here. And many a times the doctor will call over the phone. No divulging of information over the phone. They will say, I'm calling from Australia. Can I speak to the doctor in charge? No, ask them to come in front of you. Okay. The other issue also in Malaysia, the dynamic is marriages. You may have the wife appearing one day, signing the consent, and the very next day someone else turns. And I'm talking to the lady, who are you? I've spoke to someone. I'm the wife. I said, no, I spoke to another person. That's the mistress. So it has happened before. So be very, very careful. And of course, it gives a sour face. How did the lady sign this document and you didn't ask my permission? So be very careful. You might get caught out in those kind of family dynamics as well. Okay. Ms. Charlene spoke about Bolem, Bolito, or whatnot. The law on consent, I mean, today, it has moved from Rogers and Whittaker, which is what most of us have been taught of it. Now, a little bit more evolved into what is called Montgomery. Montgomery is one of the latest case laws that is actually being applied. And I just spoke to Charlene about the Shah Alam High Court case. If you have time, do go and pick up. I mean, it's actually available there. A surgeon who performed a total gastric and esophagectomy, distal esophagectomy on a so-called early tumor of the esophagus. The issue was the patient eventually died of sepsis and whatnot, anastomotic leak and stuff like that. Family sued. The dispute was centered around, did you give an alternative option to this particular massive advanced surgical procedure? The answer was, the surgical site expert witness said that potentially a EMR, endoscopic mucosal resection, could have been offered, but that was not offered. So the Montgomery principle was actually applied, where you should actually give alternatives, options for the patient to consider as well. This Montgomery was basically a mother who went into labor, had shoulder dystocia, and the argument was they did not give me an option of an elective cesarean section. So law has evolved. In fact, in 5 years' time, there will be completely another set of law as well that will come into play as well. So just be very mindful of things. Okay, that's going to go through that. Now, I think, Ms. Eileen, when you're talking about amniotic fluid embolism, I think it was about Zul Hasnima, right? The case. All right, that's one of those things that Zul Hasnima was basically in 2014, where the federal court finally decided standard of care will follow Bolem and Bolito. Consent is Rogers and Whittaker, meaning that the patient must be informed of risk, material risk to the patient. All right, this was a very sad case. How many anesthetists had inserted a laryngeal mask? Everyone, basically. How many have honestly told the patient that while the eye surgeon is doing your surgery, you may buck on the tube and potentially cause blindness? No way, right? So this is one of the things that sometimes can happen. And with the fault, there was a fault assigned that such a thing was not explained to the patient. Again, an extension of Montgomery. I won't go to too details, but this was a Singapore case of a Malaysian patient who actually went to Singapore for treatment. Use this in a very sparing manner. I'm not saying that you must actually use this at all times, but certain times the court does allow a therapeutic privilege, right? It lets you hold back information when you're sharing it would seriously harm the patient if you have withheld you have given that information. Okay, it is not an excuse to avoid the hard conversation. You must speak to the patient about the risk if it's need to, right? You cannot say it's my therapeutic privilege to withhold this information because the patient will get upset, or she might say no and look for another doctor. That is not how you use therapeutic privilege, all right? So basically this was actually explored in detail in this particular case of Hitchcock versus Lucius Uila, the surgeon who did on this, the surgery for this patient. Okay, Now, spousal consent, yes, another issue in Malaysia. 2 court cases have looked at it. Case number 1 involves, of course, hysterectomy. Nowadays, I think it's standard, right? Pretty much you do need to get the husband's consent as well, for the, especially for the rights of reproductive rights. I don't know, Charlene's looking at me. Do you? No. But it seems to be standard. Most of the time, a lot of doctors actually ask the husband to sign as well. Now, this case, polypectomy was the plan, ended up with a hysterectomy. Husband was in the vicinity of the hospital, but the consent was not obtained from the husband. The wife was already under GA. Surgeon proceeded to do. Later on, only told the family that a hysterectomy was performed. So a lot of failures along the way. But basically, the court actually ruled that, look, the husband's reproductive right must also be respected, and he will also potentially be needed to consent for this. An HKL case when I was there as well, basically, intestinal obstruction. The wife didn't want the Ralph tube to be put in prior to the induction of the anesthesia. Like Murphy's Law, whatever can go wrong will go wrong. 99 times when you put a tube down, nothing will happen. That one time that you would do induction rapid sequence, the whole content of the stomach comes out, all right? Unfortunately, the court looked at it like, if you had asked, apparently for this case, the husband was the decision maker. Even the husband could have potentially told the wife, insert the Ralph tube before they done the anesthesia. So the court viewed it as, probably may have to get the husband in to get the consent as well. Very, very challenging situation. Now, basically, does that mean that if the wife don't want, the husband can override the decision of the wife? Again, something that is very subjective and difficult to explain. Now, this was only last week. Another case of a blood donation that went wrong. Right, the guy had a venous section. Unfortunately, I think punctured the artery, brachial artery, I think, and then ended up with a pseudoaneurysm. Now, you did not explain the risk of an arterial injury from this blood donation. Again, something that how many of us have actually given blood before? How many of us have actually said, usually it's infection, some pucat a bit, blood pressure low a bit, that's it. But nobody really says you get your artery injured as well. So a lot of times, this is actually now being looked at again in detail. So material risk, that means the risk would have been relevant to the patient, you would have need to tell them as well. Okay, what would I tell all my anesthetic colleagues here? First of all, remember, consent is not just a signature, it is a process. Keep it voluntary, ongoing, free of pressure, with respect to the patient autonomy. Give your warnings of all the risks, patient-centered, okay? Meaning to say that remember what the patient may consider as material to him, right? Just because it's routine, it's not risk-free, all right? Just because your intubation is routine, it doesn't mean that you may not have a tracheal injury or a vocal cord injury or whatever. Just remember all of that. Just because you are inserting an arterial line doesn't mean that you may not cause a gangrene of the hand. All of that are things that is material and important to the patient. Okay? Finally, this is key, like what Charlene said. 6 years from now, would you be able to remember and say that I told this patient this is this? No, this is what you need to do. Please document all of this. Please make sure your consent form is filled up properly. Now, in the spirit of World Cup, okay, how many of you know this character in the center? Please don't disappoint me. Allah, hi. In this generation, this is L phenomenon. This is Ronaldo. I'm sure you all know R7, I think. This is R9, the original. Okay, all right. The R9 is like when you get a letter from the famous company law firm PSR, okay, PS, blah blah blah. They are the experts. They are just waiting for a gap. Okay, once they get that gap, they will definitely score the goal. 100% one. All right. So it's the duty of you. There are two defenders there, all both famous, Cannavaro and Maldini. All right. Charlene is like our Cannavaro. Okay. They are one part of your defense. Okay. They'll come to the court. They'll defend you to the best of their ability. But Maldini is your medical records, your documentation, your consent taking, all of that. These two together is the only way you can prevent Ronaldo from scoring. And this picture, they did prevent Ronaldo from scoring. So it is very important to understand that without one another, so if your medical records consent taking is perfect, but your lawyer, unfortunately, is not up to the mark, you're screwed as well. All right? No offense to Charlene, her team is one of the best. If you can get her, you're quite lucky. But nevertheless, there are various degrees of lawyers out there. So you got to be very mindful. This process of you going to court is not a passive process. You as a doctor, your career and reputation is on the line. You have to be actively involved. If the lawyer is asking for 6 hours, so be it. If the lawyer is asking for one whole day to sit with you, so be it. You have to be really prepared to go to the court to fight the battle of your life. Because the few doctor friends that I've spoken to when they have lost a lot of things, all right? Up here, lost the ability to function in future cases, lost the feeling of not wanting to go to work, lost. So the fraternity loses a lot if we don't take this matter seriously, all right? Fortunately, the expert witnesses is going to retire from that job, I hope. So now it's up to the current generation of expert witnesses to step up the game. All right, we need to replace the guns for hire who have done enough damage to the fraternity. All right, we need to start having expert witnesses who are able to come to the court and say, look, this doctor didn't do anything wrong, but he was not perfect. But in that situation, in that circumstances, he did what I would have done as well. That's all the court wants to know. That is the bolito. Is it logical that this guy did the thing? I would have done the same. Not such a thing like I would have done an emergency cricothyroidectomy by this, by that, all that drama, ding bang, all that comes out. When we all know it's not possible. All right. So how you're going to defend yourself in the court is when to have an expert witness who's able to debunk the other expert witness by saying that expert witness is talking BS. All right. That is the way to go about it. Okay. With that, I thank you and leave it back to Dr. Wan. Yeah.
Hello. Okay. So I invite Charlene now onto the stage for the Q&A session. Sorry, I'll go through the front. Okay. Maybe guess so I can face both of you. Yeah. Is that right? Yeah. Is there another mic? Okay. Thank you for your talk, Guna. And thank you to the audience. I see there's few questions here to go through. At the moment, we have 6. Well done.
Good.
Okay. We'll go for first question. All right. Are doctors' medical legal issues overrated compared to other professions when even more lives can be at stake, like engineers, contractors, or firefighters?
If you ask me, the media thrives on sensationalism. All right. If you have a doctor botching up a surgery and the payout is 5 million, that is a far exciting news compared to a building that just collapsed and then only a building is collapsed and no injuries and stuff like that. Yeah. That's a very draggy, long with the process. Ever since 2016, medical legal has always been there for a long time, but 2016 onwards, that is the ground-defining change that happened when the MMC made it mandatory that all doctors have to have indemnity insurance. From then onwards, everybody's lights opened up, all right? Everybody's eyes opened up to the fact that, look, now the doctors are all insured. If I have an injury, I will actually go after the doctor by assigning a lawyer for me, because I know now there is a payout that potentially is coming from the insurance side. I need to just go in there. In fact, a lot of cases that last time used to be ignored now is coming up purely because this avenue is now available for the patient. So yes, short answer is it is becoming a little bit more prominent compared to the other fields, but it's purely because of sensationalism. I don't have the data for that, but I can say that it is quite significant.
Charlene?
I agree to a large extent actually. So just for context, our firm also has a very large construction department. So trust me, engineers also do get sued quite a bit. But I think the thing with doctors is that it's very personal, right? And it's personal on both sides. It's always a very sad case on the patient side And we as doctors and the defense side, we're not saying that it's not sad, right? And then on the doctors, it's also very personal because your entire training is to help and treat people. And the allegation is always the exact opposite. You didn't do enough. You made me injured. You killed my husband, that kind of thing. So I also think it's about the nature. But do I think that doctors are getting more heat than other professions? Maybe slightly, but I think it also comes with the territory. But I also do feel that other professions also do get hit quite badly. It's just that they don't turn up in the news as often as doctors.
Yeah, it gets sensationalized. Yeah, yeah. I think that's the other thing that we think that we get more of highlight because it's in the news. Yeah. Okay. Second one. Is there a possibility of foul play and cartel in medical legal industry? Very big words. Especially looking at how expert witnesses in some disciplines tend to bring down their colleagues.
Okay, this one is a very controversial question, and the answer will be very controversial as well. As far as we, on a professional level, we don't have any evidence. So we have to go by the evidence, right? I personally have not seen the evidence. The illusion or the assumption is there, because especially when you see a particular law firm engaging repeatedly the same pool of expert witnesses for the same kind of cases with the same kind of outcome. It's kind of like, it's like deja vu again. Who is the party? Who is the expert? Is this expert? It's like a tag team lah. Obstetric mean must be this, anesthesia mean must be this by this firm. So it's almost like something like that. Now, whether there is some parties within the hospital who's leaking information or sending those cases to the law firms or whatever, I don't know. I don't have any evidence of that. But is the industry extremely ethical when it comes to financial transactions or whatnot? I think the answer you all know lah. There are some bad sheep out there. I think as doctors, especially when it comes to insurance and whatnot, when payout, we do see some characters out there who will potentially abuse the system. But until and unless a aggrieved party goes to the Bar Council or the MMC with evidence, we can't say for sure.
Yours?
I'm trying so hard to avoid this question. Okay, it's funny because I've actually been told when I visited relatives in the government hospital that yes, there are people who they know who will come and collect information. They would actually be allowed into the ward and flip through the patient's notes. And that's how they contact the family members. But I tell you what the problem is. These people are not doctors, and neither are they lawyers. So you don't have a professional body that actually regulates them. Whether or not it actually happens, I'm not sure. I don't think the person who told me that had any reason to lie. They didn't even know I was a lawyer. They just thought I was, they knew I was the niece of the patient. That was it. And I was extremely shocked. But let's move on to, I guess, the more important issue. Whether or not there is an arrangement on the back, I think from the facts, one can infer. But do we have hard evidence? I don't think so. At least I don't. But what is pertinent is this. I think we all have to be responsible for our own decisions we make and our own actions. I don't see how a profession should be dictated by one or two individuals. We shouldn't allow that to happen. And let me just say, from a lawyer's perspective, the anesthetists in our country are among the most vocal and united group of specialists that have spoken up against the right issues. I truly commend you all. And I know that the people on stage are also instrumental in that. Your leaders in your societies are also really good leaders. They are steering the discussion in the right way. You may not see it on the ground yet, but from a legal perspective, we are seeing the shift. We are seeing the shift. And as Dr. Guna said, the old guards, the guards are shifting. There's going to be a change of guards, right? They are retiring, the older ones, and we need the new ones to come up. We need the new ones to define what are the standards that you think you should be held to. That is fully within your prerogative. And you are perhaps one of the most united specialization specialists in the country. And I just implore you and encourage you to please maintain that. Please maintain that. We lawyers, we're always there to support, but continue doing that. Continue knocking on the doors. Continue having the tough discussions. When a decision that comes up and you feel medically something is wrong, have that discussion, of course, in a respectful manner, right? Always in a respectful manner. But have those discussions, because those discussions have actually now reached the judiciary. I was just sharing. A few of us lawyers in Medicolegal, we received a letter from the Bar Council saying, you know, they've been appointing us to a task force. And I said, what is this task force for? And we found out that actually the judges then, after the uproar, okay, I'm just going to call a spade, after Columbia Asia, anesthetists, and after the case that I discussed, word went back to the judiciary that, hey, how did the courts decide that way? And they're actually looking at it. So it is not falling on deaf ears. So keep up the good work.
Thank you. Okay, moving on. Okay, so maybe one of the things that may deter someone coming forward as an expert witness. Okay, so can expert be questioned by the prosecutor about their credentials and past history to discredit them? For example, being complained in CISPA, you know how everyone can CISPA you? No, it's an actual word, not like grab. It's CISPA. I've been CISPA'd, you know, like, so criminal and criminal report.
CISPA might be coming up in the next Webster's dictionary as a term. Okay, yes, you can. And that is why sometimes if you take a job as take the role of the expert witness, you yourself must tell yourself whether do I qualify so that I'm not discredited in the court. So for example, I'm a general anesthetist with cardiac, so I can talk about a lot of stuff, including cardiac and neuro and whatnot. But if I'm, say, anesthetist in IGN, for example, who only doing heart, and then I'm asked to go to court to do, say, an obstetric case, for example. When my last obstetric case was 20 years ago, then the prosecution may come to say, look, you do not fit the criteria of an expert witness there. So when the law firm actually seeks out expert witnesses, they also take into consideration that part as well, that who exactly are we asking for. Most of the time, like Charlene's team, or sometimes many other law firms actually reach out to members of the college. So they will actually call us and ask, who do you think would fit best for this particular thing? And then we will actually say, for this particular issue, best to get among the 5 of these guys, one of them should actually be the one. So we kind of like, as a society, like what Charlene said, we have streamlined the process in a way that we have a pool of expert witnesses that hopefully will come forward. The thing is, do not be intimidated by your lawyers on the other end if you have nothing to hide in terms of your credentials. If you are good in what you do, it doesn't matter, because at the end of the day, you're being questioned by a lawyer. You're not being questioned by Prof. Gracie or Prof. Karis. Arwah Prof. Karis, yes. You're not being answered by, asked a Viva question, you know. Basically, you are going up for your medical knowledge against the lawyer. So you should actually be confident of your own credentials to go and argue in court. So don't be intimidated. But again, when you are assigned the task, the lawyers do give you some time to think about it. That, doctor, do you think that you can be a credible expert witness for this case? So read, discuss, and then commit. Once you commit, this one is the next step. Go all out. Go all out, meaning that please take a good look at the case and defend to the best of your ability.
Yeah, I just add. So this CISPA thing is really getting out of hand. Okay, I've had to defend a doctor in the MMC because she kena CISPA. She got CISPA'd by another doctor, yeah? And the other doctor thought that she was going to CISPA the doctor, so the doctor thought, I'll CISPA you first. Wah. Punya complex, tapi tak complex pun, right? So, I mean, if it is small things like that, I don't think it would affect your credibility. But the one tip that I'll just say is that please disclose everything to your lawyers. And if you're not sure, ask them, hey, I had this one really odd blah, blah, blah. It may or may not come up. If it comes up, this one, it was resolved, whatever. Because there was one time actually, we had one of the best experts I've ever had in terms of making me understand. He's an electrophysiologist. So he had to teach me all about pacemakers, okay? He had an issue where a patient had went to complain about him about some, not even a medical thing, and it went into the news. Okay, so there is, if you actually Google his name, that article will come out at like number 9 or 10. And he told me, Charlene, this will come up. It was resolved, it was withdrawn, blah, 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 and everything. I am so good. And I actually had to fight a little bit to make him my expert internally. Okay, not the firm, but I think the insurers and all that. And I said, no, unless you can find me someone as good as him, I will defend him if need be. He turned out to be the best expert I have had to date. After his report, the plaintiff withdrew the case. Okay, so if you're not sure, and if something is small like this is thing, I think just tell your lawyers and maybe decide together with them. Yeah.
But no one wishes to be CISPAT. Okay. All right. All right. Next one. Okay, so maybe this is Guna, but definitely from your side, from the legal point. So for anesthetists, what's too little and too much explaining regarding the consent, especially when there is a long list of debilitating complications, including death? You actually mentioned the D word every time.
So if you, like what I've mentioned earlier, there's no way, it's pretty much impossible to cover every single complication, the too little or the too much. So again, I would actually tailor it to what the individual patient that you're looking at. For example, I routinely say, for example, I do a cardiac case, for example. If the cardiac patient is an elderly 70-year-old uncle who has minimal medical knowledge, I would not do the consent with him alone. I'll make sure that I have together with him, his daughter or the wife or the family member, to actually be able to have a discussion about the whole risk together, so that even if the uncle doesn't understand, the next of kin have a better idea in terms of what are the risks and complications. And then I'll go through with them the sequence of the minor risk, the moderate risk, and the high risk that are likely to happen as well. So if I can cover the grounds in terms of say 80 to 90% of the thing, then I'm quite comfortable to just move on and anesthetize the patient. But again, context matters lah. If the guy is like Charlene's father coming to me for surgery, then I would actually say that I would definitely spend a longer period of time, not only talking to the father, but I also talk to Charlene as well.
We're so kind.
Yes, exactly. Call and make sure that they understand that this is the steps that we are taking, right? Not because I'm not confident of my skills. I'm just worried that sometimes things may not go as planned. And medicine is such that the chances of things going not as planned is significant. It's there. So we cannot run away from dealing with complications, but at least we have some kind of a foundation for which we say, this is from where I stood earlier, this is what I meant, hopefully this is what the family will understand. If the main thing is the relationship that you build at that engagement, if the engagement has been good, if you have won the confidence of the family, the minor money trivial issues that happens later on is something that potentially the family can forgive, forget, and move on. That's my take on that.
So it's very difficult, but let me just give you a practical tip, right? Because you know what the law requires. I was in Oxford last month, and in a panel discussion, a PhD student had asked me a question and said, as a lawyer, what kind of documentation are you looking for? And obviously I was so stressed. But actually coming to think about it, and this was my answer. You have to do what you feel is appropriate at that time. You know what the law requires, right? Risks that are significant to the patient. So let me give you a practical tip when it comes to documenting. It is impossible and impractical to list down every single risk. So you will have a consent form, and that will be a lot of risks you take, whatever you sign. In your clinical notes, may I suggest that you also write, explain risks and options, including 1, 2, 3, 4, the main ones. The word including would be the word that will help me in court. Because then I said they explain the risk, including, and this was the emphasis, but it doesn't mean it is only those risks. Okay, so as opposed to just explain risk and you put 1, 2, 3, 4, then it's very easy to argue, but this other risk number 5 is not there. And you always know, you always think that for this patient, this is important. Tapi bila the adverse outcome, whatever you did actually in the consultation room, they said they didn't. And if there's proof that you did, they will say they don't understand. So please just maybe put the word including. All right. And then your consent form, if you're going through the form, and I've had cases where I've had to argue that the pen marks that the doctor made on the consent form, some was like just a dot, some circle and some tick, showed that he had gone through the consent form, and the patient in cross-examination actually said, oh yeah, I agreed. But I didn't understand. And that was enough for me, because I told the court, the doctor did. If the patient didn't understand, it's duty on the patient to also ask questions. It cannot just be the doctor reading the patient's mind. Okay, so your notes, put in advice of risks, including, and then you list the important ones.
And I can bet you that tomorrow all your consent form will have the bulat.
Okay, but you don't simply just must go through
No,
lah.
I have actually done that ever since I passed out from my master's. All my consent form will have the bulat. In a very quick manner, I'll just highlight, talk. While I'm bullating, I'm talking to the patient and telling him. So it demonstrates that you had engaged with the patient. But don't bulat after the event lah. That one is lying already lah.
So in relation, next thing is about the high risk consent. So the glorified high risk consent, the standard one that we bulat and okay. So where in that form we put high risk? Yeah. So the soalan is, how valid is high risk consent when family disagrees for treatment but patient wants it? The patient agrees to undergo the high risk procedure. So when there's a clash.
This is bordering into ethics lah. So the consent has been done as best of the doctor's ability. Now the patient who is of adequate mental capacity, he's not demented, he's not intoxicated or whatever, he is making the call of trying to do the surgery for himself. So he's got the autonomy to decide lah, right? Now whether the family member agrees or not, hopefully it's something that we as doctors can be in the middle and say that, look, for example, the process of communicating, maybe it might be what we call a family counseling kind of a thing, where you can sit down with the family members and address what are the issues that they are dead against the father going for this particular surgery. And we can, without explicitly guaranteeing a good outcome, we at least address some of their concerns in that thing. Hopefully they will be convinced enough to say that, look, okay, if that is what my father wants, and this is what the doctor will do to negate or minimize the risk, then hopefully they will be coming on our side. Now, if say die, they don't want the surgery and whatnot, then I think it will be escalated to the hospital medical ethics board lah. So where basically, especially if time is still on your side, then you're better protected if you have a group of peers of the hospital together with the hospital management saying that, look, this is what the patient wants, this is what the family are dead against. What should I do as a doctor going for this, anesthetizing this patient? And then a sequence of event will start where the hospital lawyers may potentially get involved to advise the management on how to go about it. But bear in mind, this is all in the ideal world where time is actually not a factor. But if you're rushing, you may have other issues as well.
So question to Charlene, going off, spin off from here. Is there such thing, high risk consent, that can stand in the court?
So actually all consent is the same. Yes.
In the eye of court, it's the same.
The ingredients are the same, the test is the same.
The fact that we tambah
Yeah,
high.
the doctors like to say, but it's a high risk consent. And I'm like, tapi apa maksudnya?
Okay.
Right? But I think what it means is like, we were more careful.
More careful, more detailed, more discussion.
As a lawyer, I don't like to say that because it implies that other procedures, you are not careful, you're not detailed, you know what I mean? So you should just say consent.
So consent to, in the eye of law, is the same. If there's such thing as a normal consent.
Yeah. So in my center, we don't have a separate high risk consent form. A consent form is standard, but there will be an area, a column where we fill up all pertinent high risk has been explained, including cardiovascular collapse or whatever. So what we are saying is not a high risk consent, but it's a high risk that has been explained. and that is part of our consent form.
There's some extra thing they do also in high risk. So they put in the notes and then they get the